How are you today, doctor? Well? Well, you will be now with Vitality Active Rewards for doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have Discovery qualifying products or not. And it's for doctors in every healthcare setting. We know you go the extra mile for your patients, and that's why we're giving you extra Discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more Discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for doctors today.
Speculation has been about exactly what the president will announce. Will we descend down to alert level 2? And with it, what are the stipulations, all of that?
Because of you.
I fear less.
I hurt less.
Because of you, I'm back at work.
I'm playing with my children.
And our days can begin to feel normal again.
Because of you,
I know the true meaning of leadership.
Of courage.
Of love.
And I see what it means.
To truly sacrifice.
All because of you.
To all our frontline healthcare workers.
Siyabonga.
Dankie.
Enkosi. Thank you.
How are you today, doctor? Well? Well, you will be now with Vitality Active Rewards for doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have Discovery qualifying products or not. And it's for doctors in every healthcare setting. We know you go the extra mile for your patients, and that's why we're giving you extra Discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more Discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for Doctors today.
Good morning. We're going to hand over to the CEO of SAMA now, Dr. Busimusi Nhlapho.
Colleagues, esteemed colleagues, good morning. Welcome to day 2 of the summer conference. Yesterday, we had the summer taking the lead by introducing our summer leadership from myself as the CEO. We then had the summer chairperson, Dr. Mzukwa, took us through the theme of the conference and the summer program. Our president, Professor Chauke, delivered the inaugural speech of the conference. We had clinical and ethical experts covering a session on maternal health. Our keynote speaker, Professor Glenda Gray, took us through the COVID-19 research response and the lessons the country and the globe learned from fighting this pandemic. One thing that I can note is it is fitting that our keynote speaker was a woman during a Women's Month. Today's sessions are in internal medicine, then followed by positive ways forward for the healthcare post the pandemic, and the last session will be on surgery. Thank you for joining us, and let us make this day a success that it was yesterday. I'll now hand over to Dr. Kuben Naidu, who will be facilitating the internal medicine session. Thank you.
Thank you, Dr. Nhlapho. Good morning to everyone, and welcome to the internal medicine session. I am Kuben Naidu, a physician from Johannesburg, and I'm honored on behalf of the FCPSA to be invited by SAMA as a facilitator for this morning's session. The lineup that has been scheduled for this morning promises to be highly informative, and I, for one, am definitely looking forward to it. I've also been afforded the opportunity to introduce the Faculty of Consulting Physicians. The FCPSA, which was established in 2007, is a public company 100% owned and managed by various specialists. These include the dermatologist, endocrinologist, nephrologist, neurologist, us physicians, the pulmonologist, and rheumatologist for the benefit of various specialities. The aims of the society were as follows when it was first started, and this was to advance the study and knowledge of physicians, to organize regional and national events, to improve the care and treatment of patients, and to foster collaboration between specialists working in the different fields. It was also to promote education and disseminate medical-related knowledge. There are currently over 270 specialists who are active members of the FCPSA, and there are also numerous societies who are in association with the society. The FCPSA is also a member of the International Society of Internal Medicine, and Dr. Audrey Koch, our previous chair, was elected as president of the ISIM, a proud moment for us indeed. Currently, under the excellent leadership of Dr. Freek Bester, we hope to continue to expand the services of the society and continue to foster close relationships with other societies and fellowships. We would like to extend our gratitude once again to the SAMA Organizing Committee for providing us with this opportunity to be part of this excellent academic program. So without further delay, let me introduce our first speaker for this morning, Dr. J Nel. Jeremy is a physician and an infectious diseases specialist and the head of infectious diseases at Helen Joseph Hospital and Wits University. He is president of the Infectious Diseases Society of South Africa and an active member of the South African HIV Clinicians Society. He has published research in the fields of tuberculosis, non-tuberculous mycobacteria, HIV, and pneumococcal meningitis. And today we are privileged to hear him speak on a review of long COVID, its diagnostic challenges, and what we know about treatment options thus far. Over to you, Jeremy.
Hi, everyone, and welcome. I'm going to be talking today about long COVID and particularly about what we can do in terms of management. So one of the first issues is what it is, and that's actually surprisingly complicated. We understand the phrase long COVID, but many people have used post-acute sequelae of SARS-CoV-2 infection, so-called PASC. It's also sometimes called post-COVID condition. And because it's a new thing, definitions have varied. But in general, the WHO's consensus definition and the CDC's definitions can be used, and those roughly are the same sort of thing. So it's when symptoms develop following COVID-19, either the original symptoms or where the new symptoms develop after that, but within, say, about the first few months, and that they last for at least a month, sometimes 2 months, according to the CDC, and they aren't better explained by another diagnosis. So in other words, it's not like you then tripped over and broke your leg and that's a symptom from long COVID. Clearly, that's not the case. But these are really symptoms that we might attribute to long COVID that have lasted at least 1 month following the acute event. It's pretty common, and it does depend a little bit on the severity that initially occurred with the acute COVID infection. So in the beginning, if you have severe or critical COVID, which we know is a minority, so that may be under 5% of people, many of those patients experience symptoms at a month or longer duration. That's about 50 to 70% of people. Many of these are quite significant sequelae as well. Whereas for the majority of people who have mild and moderate disease, about somewhere between 5 and 50% have side effects and that last a month or so more. Though that range is very wide, and that's because the definitions have varied a lot and because of the way that these things have been ascertained has varied a lot. Some studies haven't used control groups, some have. So there's quite a lot of uncertainty about that figure, which is why the range is pretty wide. It's really important, though, when we think of long COVID, to try and place it in a sort of historical context and a medical context, because much of what we think of as long COVID is probably not unique to COVID, although there might be some aspects which are. And for example, it's well known for many decades that people who have a severe illness requiring, for example, ICU level care, often have what's called post-ICU syndrome, PICS. And these people may have obvious pulmonary and cardiac end organ damage. They may have cognitive effects from their ICU type stay. They may have psychiatric effects such as post-traumatic stress disorder. And they often have decreased exercise tolerance. And there's a kind of a cluster of symptoms which PICS is well described for many decades about. And that includes things like muscle deconditioning and sequelae of the ventilation, for example. And this is quite well known. So that's one syndrome which is probably part of long COVID. We also know that those with milder disease may have post-infectious syndromes. And for example, chronic fatigue syndrome and other sort of syndromes in that cluster, again, associate with many viral illnesses and especially with sort of milder post-infectious syndromes. So again, these sort of things are quite well known. And the question really is whether there's something unique to long COVID that's specific for COVID, or whether this is really just a collection of signs and symptoms which are well established before COVID as well. And I suspect it may be a little bit of both. Which symptoms are interesting? So this is a study from 2020, which is long by COVID standards, but I'm showing it to you mostly just so that you can compare the types of symptoms that occur during COVID with the types of symptoms that occur in the post-COVID phase. So for example, if you look here on this graph, anything on the left in the darker green is with acute COVID. So you can see there fatigue and cough and loss of smell and taste, headache, loss of appetite and muscle pains are the majority of the symptoms. Whereas those symptoms that occur mostly in the post-COVID syndromes, in other words, the long COVID, fatigue is still very dominant. Dyspnea is quite dominant still. But for example, the loss of smell and taste and loss of appetite and muscle aches are much, much, much less common. So the symptoms do differ a little bit from the acute syndrome, although many of them are continuations of the acute syndrome, just that lasted a bit longer. A better way of looking at all the symptoms is from the systematic review in the middle of 2021, which looked at over 10,000 participants from 45 studies and found about 84 discrete symptoms. And the interesting thing there again is the timing. The median time of symptoms was about 2 to 4 months. So it suggests that many people who have long COVID do have symptoms that last around about 2 to 4 months, but almost all of them get better around that sort of period. Some symptoms last longer, 6 to 8 months in this particular study. Some have been even longer than that. But for the vast majority of cases, things do get better with time. And that's really a key take-home message from the long COVID literature. If you look at what those symptoms are, if we look at those which had a sort of point estimate of more than about 25%, and more than 5 studies or so as well, we look again, about 70% of people had some symptom, but dyspnea, again, fatigue were relatively common symptoms. And if you look at this next slide, which is the rest of the symptoms, again, sleep disorders and insomnia more than 25%. And memory loss more than 25%. But you can get a sense as well from that graph and from the graphic there that the spectrum of illness is pretty wide and many different types of symptoms can occur in the long COVID literature. Compared to controls, so this is a really nice study that came out in May of this year. And that was a study which took about 300 or so people. I think the study's now up to 500, but at the time about 300 people, divided them in two, and had really people who had COVID and people who had long COVID effectively, and controls who hadn't had COVID. And so this is really comparing two controls, and we can see that, for example, those who complained of COVID sequelae had a shorter 6-minute walking distance, a little bit, so about 35 meters less in the 6 minutes. And on multiple validated surveys described a lower quality of life score, so from a variety of causes such as pain and insomnia and fatigue. However, one of the key things that came out of this study was also the risk factors. And this is what now well established across multiple studies, and they really cluster around the same group of things. Some studies find 1 or 2 extra factors, some find 1 or 2 fewer. But in general, these are the sort of major risk factors for long COVID. The initial severity of the acute COVID is a key determinant of long COVID, and that makes sense. The more severe illness you initially had, the more potential you have for lingering symptoms a month or 2 afterwards. And that, again, is well found in almost every study that has enough people of mild and severe patients to compare. It does seem to be more common with older age. If you look at the graphs, in fact, it peaks around, say, 40s, 50s, 60s, and then gets a bit less common later on. But that may just reflect fewer older people in general. But it's certainly not true, for example, that the young are at significant risk of long COVID. The female sex slightly more than males, so usually about 60-65% of the cohort is female. And any pre-existing poor health as well is a risk factor for long COVID. And that again makes some sense. If you have underlying conditions that are significant and affecting your health before COVID, COVID seems to exacerbate them in many cases. So a couple of other questions which are interesting about long COVID. One is, does the variant itself matter? Probably. So some of the data, I'm just going to show you one study, but there have been others which looked at a similar question. And this was from the UK. This was about 97,000 adults who tested positive for COVID, and they looked at those who probably got Delta versus those who probably got Omicron, and they looked at that because they separated the waves in time, much as South Africa had a separation of each wave, the dominant variant. And in those who got infected during the Omicron wave, about 4.5% got long COVID. And in those who got affected previously with the Delta wave, about 10.5%, nearly 11% of people got long COVID. So there were quite substantially fewer people who got long COVID following Omicron. And that was true even when you controlled for vaccines and when you controlled for previous infections as well. So it does seem like Omicron is less prone to cause long COVID, and that may just reflect a slightly lesser severity in the variant compared to Delta, or there may be other factors at play too. Interestingly, the best protection was if you were vaccinated within 3 months of getting infected. And you can see on the right there, this sort of graph. So the odds were about half if you had between if you were vaccinated less than 3 months before. But in fact, the odds were even lower if you were vaccinated a bit further beyond that. Do vaccines help? Because that really raises that question. People who have had breakthrough infections do seem to have a lower risk of long COVID if you've been vaccinated. And in fact, probably a good rule of thumb is that it's about half the risk of long COVID if you've been vaccinated. So that's a really important reason, and a reason still to make sure that people are vaccinated. Vaccinating people who have had long COVID may improve their symptoms too, so that's the other way around. So in other words, if you vaccinate and then get COVID, your risk of long COVID is about half. But if you have long COVID already and get vaccinated, your symptoms may improve as well. For this, we only have relatively short data out to several months after the vaccine, but at least at that point, the symptoms do seem to have improved on average, although there's considerable heterogeneity in this. So some people will describe no improvement, some people may even describe worsening, but the majority are either no improvement or slight improvement in their symptoms as well. So it's a good reason. These may come up as someone who's got long COVID, should they get vaccinated? Yeah, on average, it's going to, if anything, improve the symptoms rather than do anything else. If we look at how to diagnose this condition, a lot of interesting things start to come up, actually. So because the vast majority of people had mild to moderate COVID, so they stayed out of hospital, they certainly stayed out of ICU, those people who get long COVID following that typically don't have physical abnormalities when you examine them. And that's a key point in your own practices, because there's a lot of debate as to what tests to do, how to examine them, what things to run, and I'll cover that a little bit in a few slides' time. But it is worth pointing out that in most of these cases, there really aren't obvious physical abnormalities, and when they are, they're no more common than those who don't have long COVID. Similarly with laboratory abnormalities. So this paper, again, which I showed you earlier from May this year, really looked at long COVID sufferers compared to controls, and whether you looked at things like echocardiograms, a bunch of blood tests, including proBNP, CRP, and D-dimers, and a variety of neurocognitive tests and processing speed, episodic memory, executive functioning, for example. And pretty much none of them do you find a statistically significant difference between controls and long COVID. And that's important. And the authors of this paper actually also conclude, looking at some of these and other markers, that there's no evidence of abnormal systemic immune activation or any autoimmune disease or persistent viral infection. So it's, for the vast majority of cases of long COVID, you will not find much on the exam or on the blood tests, and that's important in terms of the diagnostics. The odds of you finding something really relate substantially to the initial severity. So when you have, for example, people who ended up in ICU for 3 weeks and then a month later still have symptoms, many of those you will find something, but for the vast majority of cases, physical exam and laboratory tests rather are pretty unremarkable. What are useful features on history? So if you get a patient who has this condition or complaint of this condition, what should you be careful to take note of on the history? So clearly the timing of COVID is very important to establish. People will link almost everything in theory to COVID or to vaccinations. It's really important to get a plausible timeline. For example, if someone had COVID a year ago and now complain of a new symptom, that's very, very unlikely to be due to COVID. Pretty much all of these long COVID symptoms start either at the acute event or at least a month or two afterwards, so not longer than about 3 months in the vast majority of cases. It's possible we'll turn up more as more data comes in, but in the meantime, it's really important to get that timing right. The severity of initial disease is also important, and like I said, and that really does predispose you in a pretty linear way to getting long COVID. Which comorbidities you have are also crucial. And that's important as well because you want to screen those comorbidities. So, for example, if you know you've got cardiac disease and now are complaining of worsening after COVID, it's important to then investigate the heart a lot. Whereas if you know you've got, say, kidney disease, it's important to check that and make sure that wasn't worsened by COVID. It's important to ask about any complications of COVID that occurred at the time, such as pulmonary emboli or renal failure, for example, because, again, that may be important clues as to what might be going on now. And any recent attempted treatment is important to elicit as well, because people have often tried multiple types of medicines, some of which may actually be harmful, and it's important to get a history of them. What about in terms of the basic screen? What could you do if you see a patient with long COVID in front of you? Well, the history, like we said, then a screening physical exam is important. So physical exams are cheap and easy to do, and it's important to do them well, even though we anticipate in the vast majority of cases you will not find abnormalities. It's important, though, to screen so that if you do find abnormalities, you can direct further investigation. And especially we're going to concentrate on the chest and cardiac exams because those are affected more commonly than not. When there is a complication that's found, and look also for DVTs and pulmonary emboli and make sure that none of those seem to apply clinically. And like I said, it's worth reinforcing again, you're unlikely to find significant abnormalities, but it's important to look because if you do, that does change what you do next. In terms of blood tests to do, now this is really important concept that pretty much none of the responsible organizations, either locally or internationally, recommend routine blood tests at all. That's not to say that no blood tests are ever done. It's just to say that in terms of long COVID, the hunt is pretty unremarkable in the vast majority of cases. And blood tests should, for the vast majority of cases, really be guided by your findings on history and exam rather than as anything pro forma and routine. Again, understanding that if you do look further, you're very unlikely to find significant abnormalities. Also, make sure that you're not wasting your time and the patient's money by going through and doing a whole laundry list of tests that even vaguely might be positive, because again, the yield is very low. So if it's suggested by history or exam, clearly there's an important reason to carry on and investigate those parts further. But in general, we don't recommend routine doing, for example, coagulation profiles or D-dimers or pro-BNP or thyroid function tests. And specifically those would be routine, sorry, not routine, but only if indicated, but really not recommended under pretty much any scenario would be repeating COVID tests such as PCR or rapids or even doing COVID serology. So if you know the person was positive before, there is no value at all in doing the serology at that point and later on now to check COVID. If the patient was unclear whether or not they had COVID before, you might argue that COVID serology may be helpful. But remember that in South Africa, about 95% of people now have had either past infection or vaccination or both. Most of the serological tests can't distinguish between them. So the odds of it being negative are incredibly low. And in fact, in some cases, the odds of it being falsely negative are higher than it being truly negative. In other words, even a negative test is not necessarily something to believe. So again, try and stay away from those COVID tests, rather do limited, if any, blood tests at all, and really concentrate mostly on history and exam, and then decide from then where you want to go. What special investigations might be useful? So a 6-minute walking test is pretty useful. It's cheap, it's easy to do. It's useful if fatigue or decreased exercise tolerance are the main complaints that the patient has, and you can get some sort of objective measure there of how far they could go in 6 minutes. This can be easily set up even in an office setting in many cases, and that can be something useful as a benchmark as well. You can see if that improves with time. Again, it's pretty low risk, low cost. It's one of the more useful things, but again, not routine, only if they're complaining of fatigue or decreased exercise tolerance. A chest x-ray may be useful as well, but again, not necessarily routinely, but rather if symptoms or signs indicate a need. So, for example, someone complaining of cough or complaining of shortness of breath, that would be an indication to consider a chest x-ray. On average, most of the chest x-rays clear up by about 12 weeks following COVID. So if the patient's in your office at that point or longer, the chest x-ray usually then is normal, although it can take longer in severe cases or in the elderly. A CT chest, which sometimes is done probably too easily, is also important not to jump to it at an early stage, because remember that the CT chest is much more sensitive than a chest x-ray and will detect abnormalities following COVID, often in months, 4 months rather, in severe cases, months and months. So the fact that it doesn't look totally normal is not necessarily a reason to worry. So, for example, in one study, there were abnormalities at 6 months or longer in about half of hospitalized cases. So be careful with that. Again, it's not to say it's got no value. In the right setting and the right interpretation can add value. Just be aware of the fact that it really shouldn't be done as a type of routine screening test, because you're going to pick up things which are not relevant. ECGs, again, not routine, but if the symptoms or signs indicate a need, such as fatigue or decreased exercise tolerance, it might be worth considering that. Echo, again, not routine, but certainly if someone had myocarditis during COVID, that would be a good reason to consider it, or if the symptoms strongly suggest a cardiac cause thereafter. And in pulmonary function testing, again, only if respiratory symptoms are persistent or worsening, not generally if there's a slow improvement. And again, the vast majority of people who seek help are actually improving with time. They're just, the slowness is worrying them. And in those cases, mostly reassurance is the right way forward, because they do get better with time. It's really for those whose symptoms are plateauing and not getting better, or indeed getting worse, that investigations are most useful. In terms of management itself, it's really a game of extrapolation. And why I say that, it's because we don't have a lot of direct evidence from COVID. It's mostly extrapolation from other similar diseases to COVID, and the hope that it applies there too. It's about individualizing a strategy, because long COVID is really a bucket of a diagnosis. It incorporates probably 10 or 12 different types of things or pathogenesis. So it's really about individualizing the management according to what the patient is complaining about. And then patience, because it's difficult and it does take time, and almost always it gets better. So the reassurance there is a key part of management that, again, as I said, pretty much everyone with long COVID eventually gets better. There are a minority who have long-term side effects, or indeed who find something not related to COVID that does need specific management, but in many cases it does get better with time, and that's an important point. Please don't forget about the psychological components and the potential for psychological components after COVID. COVID, especially when it's severe, has been associated with both depression and anxiety, and you can screen for that in your office with screening tools such as the Hospital Anxiety and Depression Scale. It's also been associated with PTSD, and you can screen for that in your office with the impact of event scale or other mechanisms. But it's really important, because it's an under-considered aspect to this, or that many of the physical symptoms may have at least psychological components to them following bad COVID especially. And it's very important to screen for these things so that you don't go down a rabbit hole in the completely wrong direction, when in fact time-based referral for psychological assistance would be more beneficial. If you have such as dyspnea, if that's the most important issue to the patient, mild dyspnea, you can usually help with breathing exercises, and that's a bit beyond the scope of this lecture, but you can see how to do them. They're really straightforward, and it helps in milder cases. Severer cases, though, should probably get to pulmonology, because there, again, it's important that they screen for something more important, something more dangerous rather, such as chronic thromboembolic disease or equivalent. Cough cough, if it's troublesome, again, you can consider a cough suppressant. Again, we try and avoid those in most cases, but where it's really the dominant syndrome, you can. And over-the-counter cough suppressant is usually okay. Really try and avoid opioids for this purpose. That's asking for trouble. Chest pain, again, not as common as the other symptoms I've listed, but you can give simple analgesia for that. In fact, non-steroidals probably works a little bit better in non-COVID types of chest pain post these severe infections. And whether that applies to COVID is not yet clear, but that's one option, as long as, of course, their kidney function is okay. For those who have taste or smell alterations, there's olfactory training, which is a very strange thing if you're not used to it, but which can offer some improvement as well. And it's been well established before COVID as things methods which may help improve that. Remember, though, that in terms of pharmacotherapy specific to long COVID, and again, here I'm excluding specific syndromes, such as if you find pulmonary emboli or if you find arrhythmias or something. But I'm saying if you don't, and if it's just a long COVID syndrome, are there any medications that work? Well, no, not that we know. And really, there's no good evidence for any specific pharmacotherapy at the moment. People are investigating this. That may change. I suspect that it's a difficult syndrome to find evidence for because of the fact that it probably contains, like I said, multiple different pathologies in different patients. Unlike, it's not one specific thing, but it's important. Vitamins, steroids, things like this for long COVID really have no proven efficacy. There are a few scenarios, though, where you would, like I said, want to refer specifically. Post-COVID organizing pneumonia, so when you have these radiological abnormalities, especially on CT scan several months out, or at least several weeks out, one randomized controlled trial looked at a bunch of different strategies of giving steroids like you would for some other organizing pneumonias outside of COVID. And they tried a bunch of things. They tried 40 milligrams for a week, 30 milligrams for a week, 20 milligrams for 2 weeks, or 10 milligrams for 2 weeks, or 10 milligrams for 6 weeks. They tried a bunch of strategies. Didn't find any significant difference between them and didn't have a control group. So it's not clear that this made any improvement as opposed to just time. Many of the people in the study did get better, but like I said, whether that's just time or whether it's the steroids is unclear. Nonetheless, it's something people do consider when you have the specific organizing pneumonia, so not in general, but where you have proven that. Myocarditis is important as well. And with myocarditis, there's people who've had myocarditis should be assessed prior to return to work, especially physically strenuous work. And for those with fatigue, graded exercise programs are controversial. So with those who sort of fall along more the chronic fatigue syndrome, graded exercise programs may be less useful or even harmful. But again, it's dependent on where you're assessing and where you're sitting. And then really just the last point to make here is about the real importance of having a bunch of referrals and a multidisciplinary team. So if you're either working in this team or if you can refer to occupational therapy, speech therapy, physiotherapy, psychology, other rehabilitation experts, this is really the crux and the key of this sort of condition. Many people on this list here are far more experienced at this sort of thing than the average doctor, and really should be referred and used routinely in many cases where you think there's a potential for benefit. We know from outcomes that if there's one randomized control trial, and that if people did get rehab for those people who developed hospitalized COVID, there was an improvement in pulmonary function and 6-minute walking tests and quality of life. So we do think this works, but there's not a lot of evidence in COVID. And the most important way to prevent long COVID, of course, is to vaccinate. You can't really prevent infections these days, but you can certainly prevent vaccination. So again, the key points here, the diagnosis is one of exclusion. There are two big groups to long COVID, those who've sat in ICU for a long time and have probably PICS, versus the sort of post-infectious syndrome, which is much more common and where you were unlikely to find evidence on exam or special investigations. Symptoms pretty much always do get better with time, and that's really important reassurance that you can provide, especially if you don't find any other objective features. Don't forget about psychological components to this, at least to screen for them, because they can be important. A multidisciplinary team is probably the most important aspect of managing patients with long COVID. And really, there's no specific pharmacological therapy for long COVID in itself, unless you find other aspects which warrant specific treatment. So thanks very much, and I hope that's been helpful.
Thanks, Jeremy, for a really excellent overview on quite a difficult topic. One wonders how far to investigate these patients, and I'm sure we're going to have more discussion in the Q&A session towards the end. With saying that, can I please encourage all the doctors, whoever has a question, please just put it in the Q&A chat box, and we'll definitely get to it during our session after the speakers. So moving on to our next informative talk is Dr. Krause. Dr. Krause is a family physician with a master's degree in palliative medicine and a postgraduate diploma in health professional education. She is currently the head of the Division of Interdisciplinary Palliative Care and Medicine and in the Department of Family Medicine and Public Health at UCT, as well as the convener of the postgraduate diploma in palliative medicine. Dr. Krause serves as a board member of the African Palliative Care Association and PALPRAC, the South African Palliative Medicine Practitioners Association. And her current research interest is in the strengthening and integration of palliative care practices in hospitals. Dr. Krause is currently doing a PhD in integrating palliative care in academic teaching hospitals within the Department of Family Medicine at UCT. And today, her and her colleagues, Dr. Krause, Mr. Mandikiana, and Dr. Hofmeyer, will be discussing palliative care. Over to you guys.
Good morning, everybody. I'm Dr. Renee Krause from the University of Cape Town, and I'm presenting today with Mr. Lawrence Mandikiana from the National Department of Health, and we are drawing from research from one of my students, Dr. Graham Hofmeyer. We know in South Africa that many patients don't have access to palliative care. It is estimated that 50% to 45% of patients at the end of their lives actually require palliative care. And very important is to see that this is not just cancer patients, but also patients with end organ failure and with TB and HIV. During the COVID pandemic, we've realized the impact on patients and families when there is no access to palliative care. But unfortunately, only 4 to 5% of patients and their families actually have access to palliative care. But why is that? Is it because we don't have money? No, I don't think so. I think it's the value we give to patients at the end of their lives. It's the value we put to patients who are busy dying. And this quote that I've put here at the bottom, "We leave the interns to look after the dying patients," is a common sentence I hear often, where patients at the end of their lives are not valued, and the care that these patients require and need is not always valued. It's the way we look at end-of-life care that is becoming a real problem in South Africa. And this is evident when we look at the research that has been done internationally. In this study, a cross-country comparison of experts' assessment of the quality of death and dying in South Africa, we can see that South Africa did very poorly internationally. We were the 73rd country out of 81 when they looked at the quality of death and dying in our country. And from the right-hand side, you can see that it's not purely medical factors that were thought of, but it's factors like family care, spiritual care, good communication. These are the fundamental factors that are required when patients are dying. But what were the factors that were making patients die so bad in our country? And how can these factors actually be addressed and become real in our lives so that we can operationally address these things? So in this study, they looked at factors that positively improved quality of life of patients. And firstly, it was the access to opioids. It was that there was money invested in palliative care and end-of-life care, and that patient had free or low-cost access to palliative care. The government needs to take responsibility and take oversight and responsibility towards end-of-life care and palliative care, and that it cannot just remain an NGO function. If we look at the access of opioids in our country, and this is from a study here in the Western Cape, that we saw that patients actually mainly access opioids at tertiary level, and they will probably only receive a repeat prescription from a tertiary level hospital. Patients at primary care settings, and I can say and boldly say that even in rural settings, patients have very limited access to strong opioids. This study goes further to say what are the things that can also improve end-of-life care, and fundamentally is education. And it cannot be, if I want to be educated, it needs to be mandatory education in palliative care and end-of-life care. And if you don't understand this slide, then you require education in palliative care. These are some of the basic principles of end-of-life care and palliative care. And many doctors still don't understand these basic concepts on how to look after patients at the end of life. But it's not just at undergraduate level that we require training. It's across the continuum of our developing our specialists in our hospitals that require proper palliative care training. And one of the aspects that is missing in South Africa is the access to specialist palliative care. Fundamentally, we are still in a process of not being able to register the speciality of palliative care. And without leaders and clinical leaders in the field, this area of medicine will not develop according to the training and the research and the other aspects of governance that is required around end-of-life care and delivering of palliative care to patients. Factors that were seen as really contributing negatively was the fact that people don't value or see end-of-life care as a basic human right. There is limited integration of palliative care, and we know that this is a problem in our country, with only a few centers being able to deliver palliative care in our country. But there's also a financial investment. This will not just happen. There needs to be a financial commitment from the Department of Health and from other departments of health and from medical aids to actually ensure that patients have good access to end-of-life care. One thing that we can be sure of is that this is the kind of care that most probably all of us will require. And there it is again, it's the lack of training that doctors, nurses, and other healthcare professionals do not know on how to look after patients at the end of life. And when you go on to the factors, you will see it becomes more and more non-medical. And probably it's when we feel that there's not another grand operation or a grand special investigation that we can do, that we limit the value that needs to be provided and the care that needs to be provided to that patient. We don't think it's sexy, or we don't think it's the best care, but it's bringing that excellence back into how we look after patients at the end of life and valuing that as good care, excellent care, care that all healthcare professionals need to be able to deliver. This is how we're going to integrate palliative care. It's not going to be something that is just going to be able to be fixed with money. It's something that's going to happen within all healthcare professionals, where we say that patient who is at the end of their lives has value, and I need to spend an equal amount of time in caring for that patient. There's value for healthcare professionals knowing what to do, how to give the care, because ultimately not being able to do something when you are witnessing suffering does cause moral distress within the healthcare professional. And we are very grateful that the National Department of Health is starting to do something. We do have a policy, but there's still a lot of investment that will be required from across the country and from the National Department of Health to ensure patients have better access to care. And I'm going to hand over now to my colleague from the National Department of Health to tell you where we are at with integrating palliative care. Thank you very much.
Thank you very much. As mentioned, my name is Lawrence Mandikiana. I'm just going to be talking about the integration of palliative care in South Africa, mainly focusing on the national policy framework and strategy on palliative care. So when we're looking into the national policy framework and strategy of palliative care, we have to be cognizant of the fact that South Africa played a major role when it comes to the development of the World Health Assembly Resolution 67.19. Which calls for the strengthening of palliative care as a component of comprehensive care throughout life course. So this resolution calls for the integration of palliative care into the public health services. So we are trying to say palliative care should also form component of all the services which are offered into the public sphere of healthcare services. So in response to this, the South African government developed the National Policy Framework and Strategy for Palliative Care, which is a policy document which tries to explain and to also help the integration of palliative care into the public health setup. So how this is going to be panning out, or how this is panning out, the policy is being implemented as a way of cost effectiveness. So in this regard, we are trying to allude to say if it is the management of HIV services in healthcare facilities, they're also integrated with palliative care as a form of cost saving. Whatever services are being rendered, they are also integrated. So there is no need to duplicate services, but otherwise to operate in a more of a co-jointly form of service provisions. So that being said, everything which is being done, it is also being done in the policy implementation in alignment with the COVID-19 regulations. And then there's also the issue of also coming up with a specified palliative care contingency of plan and care, which are also in line with COVID-19 regulations. So some might ask to say the policy framework, what is it all about? What are the main objectives which we are focusing on when it comes to implementation of this policy? So the policy comes with 5 goals. So the first goal, which is to strengthen palliative care services across all levels of healthcare. So in this first goal, we are mainly focusing in the issue of addressing the issues of availability of essential medicines. So in this case, we are mainly looking into the availability of morphine and other essential commodities. And then coming on to goal 2, which talks about to ensure that there is an adequate number of appropriately trained healthcare workers. So in this case, we are mainly looking into the provision of the 3 essential forms of training as alluded in the palliative care policy framework. The first one being the availability of the basic in-service training, and then the second one, the intermediate training, and then the specialized training. But in this case, because of the magnitude and the quantities of healthcare workers across the country, we are mainly focusing on the availability, making the basic in-service training available to healthcare workers. So the basic in-service training is just a 5-day training course which trains on symptoms management, your psychosocial care, spiritual care, which gives just a brief overview of how palliative care is all about and how to assist palliative care patients. And then due to the implementation of this policy using the SMART analysis, we are so specific in terms of attaining high quality of implementation. So that being said, goal number 3, which is the implementation of monitoring and evaluation structures. And then goal number 4, which talks about financial resource allocation, and goal number 5, which talks about strengthening of governance. We are going to be implementing these goals from 2023 going onwards. So in the present moment, we are just implementing goal number 1 and goal number 2. So as we go with this presentation, I'm just going to explain to you what do we mean when we say we are strengthening access to paying essential medicines, and then also the issue of enhancing access to the basic in-service training. So moving on to the next slide. How are we implementing this policy? So we are not implementing this policy blindfolded, and we are not also integrating palliative care into the public domain blindfolded. So what we are doing is we are using an operational survey. So an operational survey, that's where we'll be using a standardized tool which gauges the current services or the current strengths which each province has, and then we align it to the policy using the outcomes from the survey as a guide to say how best can we implement palliative care or strengthen palliative care services in that province. So that being said, we are undertaking rapid surveys in all the provinces, and then based on those survey information which we get, we also support provinces accordingly. So when it comes to the implementation progress, 6 out of 9 provinces have undergone the survey. So we are talking of Western Cape, Northern Cape, Eastern Cape, KZN, Mpumalanga, and Free State. So the survey outcome is also going to feed into what we call implementation plans. Sorry for that. It's going to feed in what we call implementation plans. So implementation plans, we're trying to identify the gaps and then the strengths as well, and then we nullify everything and then putting into perspective how best we can move forward to integration of services. Moving on to the next slide, which talks about the enhancement of access to pain medication. So goal number 1, we are mainly strengthening availability of essential medicines. So in this case, the implementation progress which we have experienced at the present moment, availability of morphine is actually monitored on a quarterly and monthly basis. So what we are doing is we have access to what we call a national surveillance system. So through this surveillance system, we can always be able to check availability of the supply chain systems within each facility, district, sub-districts, province, and then we can actually share the data with provincial pharmacists and see how best we can strengthen the supply chain challenges which each province will be facing. And then also we've also want to relay the information through what we call palliative care task teams. So these task teams' main objective is to make sure that they are used as checks and balances to whatever province each province is doing, and whatever weakness has been identified by this task team, it is reported back to national, and then problems are rectified accordingly. So based on the last 2 cycles of financial years, which we have been reporting data on access to essential medicines, there have been some tremendous improvements when it comes to a reduction in stock outs, and then also improvements in the quantities which has been ordered. So moving on in the near future, we want to maintain this standard by also coming up with other indicators which can act as checks and balances in trying to make sure that all the palliative care patients, they now have access to essential medicine. So it's not just a matter of ordering of medicines, having the right stock whilst it's stocked in the warehouse, but now we want to make sure that the medication reaches to the final destination, which is the patient in their respective homes. And then moving on to the second objective, which is the second objective of making sure that there is good capacity building. The main objective here is to enhance healthcare worker capacitation when it comes to accessing the basic in-service training. So the basic in-service training is just basically small components of palliative care materials which have been put together, and these are standardized and accredited as well, whereby healthcare workers, including your nurses, doctors, and other supporting healthcare workers, are trained in terms of symptoms management, psychosocial care, spiritual care, and other essential components of palliative care. So that being said, there has been some implementation and integration progress which has been witnessed around the country. So the basic in-service training has commenced in 7 out of the 9 provinces. And then just to further on that, in future now, we just want to make sure that those upcoming nurses and doctors, they are already equipped with palliative care curriculum. So how is this going to be happening? So in the present moment, we are engaging the South African Nursing Council and the HPC SA to make sure that there is the inclusion of palliative care modules in their curriculum. So it is something which is at an advanced stage, and then the syllabuses have already been developed. So it's a matter of the revision, which is going to be coming through as soon as the next cycle of curriculum is approved by these respective boards. So that being said, we also want to scale up the basic in-service training. So on average, each and every year, there is at least less than 1,000 healthcare workers who have access to the basic in-service training. The training is rendered through service providers like, for example, the Hospice Palliative Care Association, Vets University, the University of Cape Town. We also have a group of palliative care doctors called POPIA, who are also rendering the same training. So that being said, as the department, we just want to make sure that the training goes beyond 1,000 a year. So our target is to have at least 500,000 healthcare workers trained in the next 5 years. So which means in each and every year, at least 100,000 healthcare workers should at least receive this training. So how is this going to be happening? We are in the process of making sure that there are access platforms whereby healthcare workers can access these training materials on readily available sites, which makes it easy for them to also train in a huge number. So moving on to the other cycle of integration of palliative care in South Africa, there is need to increase patient care management. So as we know, palliative care is a field of study whereby we have to make sure that pain management and symptoms control is actually managed adequately. So we just want to make sure that there is minimum to no pain in any form. It could be physical, psychosocial, or spiritual. That's what palliative care is all about. So when it comes to the implementation progress, when it comes to increased patient care management, we are in the process of developing guidelines and a user guide. So we have a children's user guide, and then we have a clinical guideline for adults. So through engagement with palliative care expert stakeholders around the country, the adult guideline is, should I say confidently, 75% complete. The user guide, it's more at least above. It's way around 80%, somewhere there complete. So when we say complete, we are trying to say most of the material are undergoing internal review. These guidelines will act as a guiding tool to all the healthcare workers to say, if a patient were to present with anxiety, how do you manage a palliative care patient patient who is going through anxiety. So it's more of pain management, symptoms management, and symptoms control. So we want to standardize care of palliative care patients in that regard. So both documents are expected to be complete by end of November 2022. We started the process in December of 2021. So within this spec of experts around the country, we are also still inviting other experts as well who might actually come to the fore to say we are willing to support the development of these documents in any capacity. Either you are an expert, palliative care expert, you would like to review the documents as an external reviewer, we are free to that. Please, maybe we can engage the workshop supervisors, and then we can just get your details and then get hold of you so that at least we can just move forward in producing quality materials. So coming to the way forward, in this current financial year of 2021-2022, we will continue enhancing universal access to essential medicines and commodities through the use of the surveillance system. We will continue monitoring availability and ordering of essential medicines, and then also the capacitation of healthcare workers through the basic in-service training. It is happening, although at a minimum pace, but we are in the process of enhancing and allocating resources to make sure that the basic and service training is accessed at a scaled up level. And then also we would like to continue establishing partnerships around all the provinces to support palliative care. So when we are saying establishing of partnerships, we have stakeholders who have been pillars of strength in supporting palliative care in the public domain. So we just want to continue integrating those partnerships. And then the development of essential documents, which is the user guide and the clinical guideline. We would like to make sure that these documents are developed with quality, and at the end of the day, they benefit the end user, who is the healthcare worker, which at the end of the day also improves the quality of care to our patients. So the National Policy and Framework and Strategy on Palliative Care is being implemented in phases, and we aim to ensuring universal health coverage, and through unwavering support from palliative care stakeholders, there has been some tremendous outcomes for patients and healthcare workers. So this is just an illustration of how stakeholders have supported palliative care in a nutshell in South Africa. Without stakeholders, I think we'll be lagging behind as a nation when it comes to integration of palliative care. That being said, thank you so much.
Thank you to our two colleagues for a really excellent overview on palliative care. And it's heartening to know that there is funding and a framework in place going forward for the really important topic, which means a lot to our patients and their families. We'll save some of the questions and discussion for the Q&A session, and we can now go on to our next speaker, which is Dr. Anthony T Behrman. He qualified from the University of Cape Town with his MBCHB in 1975, and he received his diploma in occupational health from the same said UCT in 1997. He's a foundation fellow of the Faculty of Forensic and Legal Medicine from the Royal College of Physicians in the UK as of 2005. And he's an accredited DISAC mediator at UCT Law at Work and part of the legal faculty in UCT since 2014. Some of the positions he currently holds is that he's a business and medical legal consultant to the Medical Protection Society from 1998 to 2012, and again from 2018 to date. He's also a board member of the IPA Foundation of the RSA. And on a more personal level, he's also a recreational pianist and a guitarist. So over to you, Dr. Behrman.
I'd like to thank you for joining us today, and I hope you enjoy the topics discussed. Medical Protection is the world's leading protection organisation for healthcare professionals. We go beyond defence to protect you in important ways you may not expect. Our protection is much more than patient claims, and a big part of that is helping you to avoid problems before they happen. Our focus on prevention lessens your risk, protects your career, and reduces claims. That's why we're committed to providing you with doctor-led insights, advice and professional development training at no extra cost. Each course has been developed and delivered by doctors and experts in their field to cover a comprehensive range of topics. What's more, many of our courses are also accredited, which means that they can support evidence of your professional development. We understand that your schedules are busy, so to help, we've developed many flexible ways for you to stay informed and learn, such as our range of online courses that you can start, stop and pick up wherever, whenever. With our webinars, you can participate live or on catch-up at a time that suits you. And our virtual and face-to-face workshops provide an opportunity for deep learning and skills development, along with valuable discussion with colleagues on essential medical issues. To explore all of the training options available to you, simply visit our online learning hub. Reduce your risk and protect your career with doctor-led professional development from Medical Protection.
Welcome back to part 2 of my talk on the protection of personal information. We've got quite a number of topics to cover this morning, so I'm going to proceed with alacrity. Data breaches result in extreme difficulty, extreme damage to your patient, to your reputation. It can cost you a large amount of money in fines and can result in various other forms of sanction. Now, as we said, they are almost unavoidable, but if we go through the various steps, which I'm going to explain to you in the next couple of slides, hopefully you will be able to prepare yourself well to prevent a potential data breach, and if you do have one, then you'd be ready to respond. Remember that in South Africa, there are no minimal thresholds for data breach to be reported. In other words, any data breach must be reported to the regulator. In preparation for a potential data breach, you're advised to have a written plan of action. Now, these plans need to be relatively simple and easy to follow. You need to have easy access to such a plan, and your employees should be educated at least once a year, and all new employees should undergo induction before the end of any 1 year. You need to review and update these plans on a regular basis, because periodic updating is not only essential but is also required in terms of the Act. And remember to keep very accurate records as to your staff's attendance to these and of these courses. They need to sign that they have been at a course, and you need to keep those on file. So the following are 12 specific ideas, 12, we call them elements, of a data breach response policy. Now, initially, I did mention to you earlier that you need a written document. Not only must it be written, but it must be signed and dated. Your staff need to be able to understand it with ease. It also needs to be accessible. So please use clear, non-technical language. And your policy needs to explain what a security compromise is and the nature of the urgency of such a compromise. Very importantly, in the data breach response policy, you need to identify certain people, certain tasks. Now, the person to whom the breach must be reported to internally is probably the most important person to start with. This is the information officer, and almost certainly that is going to be you as the chief executive of your business. You also need to identify and define who is responsible to report to the regulator, and then also who is expected to formulate a notification to the patients, and whose responsibility it is to contact that patient. And then how the patient will be contacted: email, snail mail, SMS, telephone call, etc. All of these are to naught unless you know exactly who is responsible to ensure that the patient receives the notification. So that's a very important function as well. Then you need to plug the hole. You need to make sure that immediate steps are taken to preclude any further loss and secure your data. That's written into the Act. And then it has to specify how to manage and assess that breach and how to prevent any further breaches. The 12th point I've left for last, and that is you need to call for help, because you almost certainly will not be able to handle this on your own. And in our instance, please contact the MPS and we will assist you should anything as horrific as a data breach occur. But as we mentioned at the beginning of these 12 points, it is almost inevitable, at least once in someone's career, that you will face a data breach. Now, we're expecting and waiting for a template from the regulator on exactly how to report the data leaks to her, but at the moment it's pending. So it's your statutory duty to notify the regulator if you have a data breach, but it has been specifically qualified to say as soon as is reasonably possible. And the word reasonability comes through the POPIA in various of my slides. So you try as best as you can. You notify as soon as reasonably possible. And then clearly you need to notify the patient unless you don't know the identity of such a patient, clearly. So how quickly must you act? Well, the notification of the patient is paramount. You can only delay that notification if the public body, for example, the South African Police Force, or the regulator herself, determines that the notification will impede a criminal investigation by the public body concerned into the data breach. But let's have a look at what is reasonably possible and what that must take into account. So there are the needs of law enforcement, which I've just pointed out to you now. There are measures necessary to determine the scope of that breach. So before you can notify either the regulator or the patient, you need to take measures to determine how wide is that breach. And then immediately, as soon as you can, and as soon as is reasonably possible, ensure that you have restored the integrity of that information. So POPIA does definitely acknowledge that first you need to plug the hole. You need to ensure the integrity of your system again before you make the report. How do we notify the patient? Well, importantly, probably more than one way of doing this. So you need to do at least two of these. So you need to send an SMS or an email to the data subject, let's call them the patient, to their last known email address. You might need to mail something to the data subject's last physical or postal address if you can't get hold of them in any other way. You may elect to put a prominent notice on your website indicating that there has been a data breach. Sometimes you might even need to put it into the news media, but be very, very careful not to re-breach that person's privacy all over again. And then there are other things which the regulator might decide, and she will communicate with you accordingly. But as I said just at the beginning of this slide, probably best to do at least two of these. Your data breach policy, therefore, should really have a standard notification which you will default to as soon as a data breach occurs, and in that would be how you are going to contact the patient. Very importantly, you need to explain to the patient the potential consequences of what has happened, the security compromise, the kind of data that has been lost, etc. The measures that you intend to take to address the security compromise, and a recommendation to the patient to mitigate the possible adverse effects of such a compromise of their personal data. And yes, if it's known to you the identity of the person who unfortunately caused the data breach. The Act specifies that the head of an institution is the IO, or the information officer. So as I mentioned, I think a little bit earlier on in this particular portion of the talk, you in a private practice are the de facto information officer. Yes, you can deputize to a deputy information officer, but the buck stops with you. You are the head peanut in the pack. All information officers have to register with the information regulator, and in fact we're supposed to have done so much earlier this year. I've put the address where you can register onto the slide, and if you haven't registered by now, please do so immediately. Many of you will recall that you were expected to produce and submit your Promotion of Access to Information Act 2 of 2000, the POPIA manual, and that can now be found at justice.gov.za at the address that I've shown you there. The POPIA now comes under the POPIA mantle, and much of the POPIA information will be found on the POPIA interface. You need to incorporate a lot, in fact all of the data in your old POPIA manual into the folder that you're compiling should you sustain an inspection, including the name of your IO and the name and the details of your information regulator. In compiling all of this information, you also need to put down very clearly the purpose for which the personal information will be acquired and processed by yourself. Also the categories of patients, of data subjects, and the type of personal information that you're going to be processing. And then to whom you're going to pass that information on. In other words, you're sending it to the operators for them to further process and send on. You need to clarify the security measures that are in your practice. And please remember that despite all of the need for privacy, all members of the multidisciplinary team may access patient data as long as this is in the interests of the patient and can be defended by yourself. On the old POPIA regulator now sitting inside the POPIA website, there are some important forms for you to use or for you to direct patients should they request access to records or corrections or deletions of any of their records. Let's just speak for a short while on information which will be transferred out of South Africa or even stored outside of South Africa. So currently, the security that you use in your data has got to be equal to or greater than the GDPR of the UK or the HIPAA, which is Health Insurance Portability and Accountability of the USA. As long as your data and the prevention and protection of your data matches the GDPR or the HIPAA, then you would be on the right side of the regulator. There are still items on cross-border storage and security of data which we are awaiting further updates from the regulator currently. Now, talking of updates from the regulator, they also, from the regulator's office, from time to time issue guidance notes. Now, it's very important to understand that these are merely guidance notes. They are not legally binding on the regulator, but they are to be taken note of, but they do not have legally binding status. Many of my colleagues have approached me often in distress and said, well, I've got so much data, I've got so many records, what do I do with all of them? Now, in terms of the POPIA, they basically indicate that after 6 years, you need to destroy all inactive files. Remember that the HPCSA says that you need to conserve all of your file data for at least 6 years. So to balance all of these, it's essential to re-consent your patients for POPIA as you start seeing them since the implementation of this Act. Any data that has been taken from them prior to the inception of the Act would fall under the general rule that you may not keep data for longer than 6 years, so you can then destroy quite a large amount of the old records of patients that have never come back, remembering that the HPC says you need a minimum of 6 years to be able to defend yourself. Now, there are numerous instances in medicine where the doctor might feel that the patient would benefit for the health of the patient, that the data should be kept for longer in case you need to have to refer back to old mammograms and surgical reports, etc. And again, so long as you can justify this, then we believe that you cannot be found wanting, providing that it isn't a blanket decision to keep all records for all time. Some of you may recall the Western, which was remade in 2016 with Denzel Washington and Ethan Hawke, which is called The Magnificent Seven. And I've basically plagiarized their name, their title, to draw your attention to the Magnificent Seven final tips for POPIA. Remember, tip 1, you are fully accountable for all of the PI in your practice. You are the information officer, and the buck stops with you. Secondly, part of your practice's duty is to process information. Not too much, not too little. In fact, I tend to call it the Goldilocks principle. Just enough. You have the right to process that information, providing that you've got consent from the patient, 1, and 2, that what you do is within the needs of the patient. Just enough information to satisfy the patient's and your needs and requirements. Then the specification of the purpose and the reason. Why are you collecting that data? And providing that you understand why you're collecting it and you've got the patient to consent to those reasons, then you can proceed to collect it, but only use the data within those agreed parameters. Following on from the previous slide, let me just move immediately to openness. In other words, full clarification to the data subject, which is the patient, as to why, what, and when you're collecting the data and making sure that you've got their express consent. So things like ICD-10 codes must be explained, not necessarily the actual code, but the reason why you're using ICD-10 and the implications of the use of ICD-10 codes. Then you may need to further process that data. And this is a bone of contention, because you can only do that, again, with the express consent of the patient. So if you're going to process that information beyond the reason for which you gathered it initially, you've got to re-consent the patient. Some individuals say if you anonymize that patient's data, then you may process it further. This is a bit of a grey area, and until this is fully clarified, I would rather urge you to get express consent for further processing, should it be necessary. The quality of your information, well, that needs to be accurate. If you put rubbish in, you're going to get garbage out. So you need accurate information, up-to-date information, information which is checked by your staff on a regular basis. There's nothing worse than sending an account out and handing an individual over to a debt collector because your receptionist failed to check their last known address. And then finally, the last of the Magnificent Seven is the adequate safeguards. I've gone into exquisite detail about what safeguards you need to use, and make sure that when you have registered with the regulator, that you have all of those safeguards in a file awaiting a potential inspection, and file the certificate which the regulator is going to send back to you as proof that you have registered. So in the last few minutes, I thought that I would just recap some of the important topics and points which we've made over the last 2 days. Most importantly is the consent. That's the basis of all POPI. So the patient says that they consent to the processing of my personal information as contemplated in PI by you and third parties that you are interacting with. The patient says, yes, treat and manage me in terms of the doctor-patient relationship, in terms of the contractual relationship between myself and the doctor, in terms of communicating with other persons as it relates to my treatment and management, in other words, referrals to specialists, etc., and then communicating with third parties who are indemnifying the patient for treatment, for payment, in other words, their medical aides and their administrators. And then also agreeing that you may collect monies which are owing from them. That's very important, because without that consent, it makes debt collection extremely difficult. Remember that this confidentiality is essential, that the staff agree to signing an agreement with you that they will maintain confidentiality as well. And just to go back to the previous slide, the confidentiality that you have with the patient is also between you and the staff, because you have certain information about the staff, not necessarily medical, but certain pension information, etc., which you have got to maintain confidentiality on as well. So confidentiality in all aspects. Your staff need to be trained in what is PI, where they can talk, where they can't talk, the kind of things that they shouldn't say just as throwaway comments, the security measures which are in your practice, the fact that they can't disclose personal information when people call in. Did Mrs. So-and-so arrive? Was she part of is she part of the waiting room at the moment, etc.? You can't actually give that information. And then what to do if there's a data breach. Remember that in all of your training with your staff, you must have proof that they attended the courses by getting them to sign and date at the end of each course. Your service providers, the folks that actually do various tasks for you working on your data, they also have to comply with POPIA, as I've pointed out to you in some of the previous slides. They need to maintain security, to treat information as personal. All of this is required in Section 19 of POPIA. And there's an obligation on them to notify you should there be even a suspicion of a data breach. They also need to indemnify in your favor against any claims, fines and penalties which flow from data breaches where they have not adequately followed Section 19. This slide is a typical operator agreement, and there are various modalities here which you need to include in your agreement. And I think what's probably important is if you photograph this slide and utilize a lot of these clauses in your agreement with the operator. So I'm going to leave that on the screen for just a couple of seconds. If you take out your cameras and just photograph this operator agreement. Okay, in the interests of time, I'm going to move on. Now to a recap on the security requirements. How are you processing data? Where are you storing it? What personal information is in your practice? And what reasonable practical steps can you take to secure the information? Remember, you do need to put together an impact assessment template, and you would get that again off the regulator's site. By way of summary, again, a data breach response document. It's a written document which you need to keep on file, easily accessible, and using clear non-technical language, and go over this again and again with your staff. You need to blend the information from your old POPIA manual into the POPIA folder. You need to register with the information regulator and be ready so that should you have an inspection, that you've got your certificate on hand, that you've got your POPIA manual blended into your POPIA folder, and that you can sustain an inspection with ease. Once again, just for a few moments, I'm going to leave some useful email addresses on the screen if you would like to take out your cameras and photograph these, but the slides will be made available, I'm sure, by SAMA. So colleagues, we've come to the end of our talk, and I hope that you're now far more familiar with POPIA as well as POPIA. If there are any questions, which I welcome, I think that we have a couple of minutes in hand. So I'm going to close the talk, and I am available now for questions from the audience. Have a wonderful weekend and enjoy the rest of the conference. And once again, thank you very much. I'm T Behrman from Medical Protection Society.
Thank you, Dr. Behrman, for a really excellent overview of a topic that I think medical practitioners tend to shy away from, but it's something we can't ignore, and we have to be part of this. So that takes us into our Q&A session. And I I'd encourage all our participants to just put whatever questions they have in the Q&A chat. And we can start off with the first question. And I think this is for our first speaker, Jeremy, from Dr. Motala. He asked, does the lung fibrosis clear up eventually? And this is probably in relation to the COVID pneumonia.
Yeah, it's a good question. Thanks. And we're still in early days a little bit with COVID. Fibrosis in general doesn't tend to get a lot better. Early fibrosis can resolve if you catch it early enough, but mostly it doesn't. But it's not true that the whole of the lung is fibrotic, is necessarily described by fibrosis. In other words, we know that organizing pneumonias post-COVID can improve with time and or with steroids, for example. There are other therapies people are looking at in terms of literally anti-fibrotic drugs being given, but those are still quite experimental at the time. I think, so this is really, this sort of thing would necessitate a referral, I think, to pulmonology and to see what they can offer at that setting. But like I said, it is certainly true that you can get improvement, although whether that's the fibrosis or other parts of it, it's more likely to be the other parts of the lung disease. And then just one thing to clear up about that question as well is the CT changes that linger after a bad COVID infection. They're not just all fibrosis. Many of the time they're kind of interstitial changes or sort of residual evidence of having a COVID pneumonia. But that, because it can last such a long time on the CT scan, is not necessarily a danger sign as long as the patient's improving and they get better. So those are kind of conceptual differences between, just the post-COVID sequelae and actual fibrosis, which is quite rare, probably about 5% of people who have bad COVID. And whether or not that gets better, it's unclear, but certainly the organizing pneumonia can improve if you catch it early enough. Thanks very much. Oh, yeah, you muted.
Sorry, technology. So yeah, thanks for that. I think that you perfectly answered that question. This is a question for Tony from Dr. Saban. May there be more than one person registered as the Deputy Information Officer?
Yes, thanks, Dr. Saban. Yes, you definitely can have Deputy Information Officers, and you can have more than one deputy if you've got a very large concern. However, whatever those deputies do will not prevent you as the information officer from having to stand or fall by whatever they've done. So you can certainly put your practice manager, or if you've got more than one practice manager as the deputy information officer for those institutions. But when the rubber hits the road you are the information officer. So that you can't protect yourself by putting in a deputy. It's very similar to the Occupational Health and Safety Act, where they're looking at the 16(2) appointees. I had a couple of other questions which I thought might come up. So if you have some time, I can offer some answers to kind of stylize things which people have asked before. If you'd like us to do that at some stage, you can just let me know.
Oh, perfect. I think there's another question that came through for you as well from Dr. Williams. Can you give us examples of data breaches you have seen?
Yeah, sure. Obviously, we can't give you live examples because the individuals themselves might be compromised, and there may well be ongoing investigations. But data breaches can happen when your computers maybe go in for repair, when your passwords are poorly protected, when you've left your appointments diary out for the next day and it's beautifully prepared with everyone and all of their contact numbers, and somebody in the practice who's maybe not necessarily signed a confidentiality with you, which I emphasize they should all sign, or somebody with evil intent from the waiting room has popped in and distracts the receptionist and takes a photograph of that page. Doctors' diaries are tremendously dangerous. I would suggest more and more that we move to electronic diaries with very good password protection. So yeah, all of those, you can have an incoming telephone call where you might ask, how is Tony Behrman? He saw you yesterday. And you have to block that and say, sorry, who are you? How can I help you? I can't confirm or deny that Tony Behrman saw you. So it's actually best that you would discuss this with the person that you're speaking about. And if you'd like him to phone or her to phone, then, go ahead. There's lots of workarounds and lots of ways that you can get yourself into difficulty. But I think the awareness is probably the most important of the lot. The other things that I just wanted to mention is I've said in both of the talks, and really the two talks were a continuum, one of the other. It's just that they're so full of facts that I thought it was best to break them up into two. How locked is locked? Do you have to have GSA security patrolling your premises with trap guns and landmines, or is it good enough to have a mortise lock on the front of your surgery, which lock you can buy from any hardware shop if you pick up the code M10H or something? Or is it somewhere in between? And yes, it is definitely somewhere in between. Clearly, you do need a burglar alarm. Clearly, you do need a proper locking device on your front door. It doesn't have to be coded, but you need a high-quality lock and possibly even two. And then your patient's files, if they are computerized, need to have the computer itself heavily password protected and backed up to a distant site, which again is also password protected. And the computer at night needs to be disconnected and locked up in a filing cabinet, and the filing cabinet itself needs to have a kind of a barring device with a padlock on it. Now, yes, you can break all of those as well, but at least you can show that you've applied your mind and you've attempted your best to protect personal information, which is the theme of this entire talk. Then I've had folks asking me, what about Facebook? So as we mentioned, in fact, we didn't mention WhatsApp yesterday. It was one of the questions which came up. It actually features more in my talk on telehealth. But bottom line on Facebook is an absolute no. You can't use Facebook. It's far too impervious to other individuals. And more importantly, is should you, Tony Behrman, decide that you want to get involved in a Facebook discussion, and if you say contentious things that can bring the profession into disrepute, the council will be on you or over you like a rash as well. So I would really encourage my Facebook colleagues to be very, very cautious using things like Facebook. Debt collection, I think I did mention, it's dangerous if the patient hasn't said that you can collect and use the data, because then the debt collector will be asked, where did you get the data from? It came from Tony's practice. no, I didn't give consent for that, and you've got egg all over your face, although there is money that's owing to you. And the last thing is referencing and sick certificates. So when you give a reference regarding a staff member, you've got to get their consent. And that consent needs to go as far as the staff member reading that reference and giving consent. Closed references now with POPIA are very contentious. And the last is a sick certificate. And can you issue that without the patient's consent? The answer is no. You can't. You can't even say that XYZ was actually here. You've got to get consent because that is personal information as well. So I never mean to frighten anyone when I give these kind of talks, but it's just that we have seen rather sad cases where lack of the law is regarded as no defense. So it's better that you know and have these manuals ready. And even if they're not perfect, the inspector or Pazi Kakula can see that you've attempted, and then you're not looking at fines of 10 million rand and jail time of 10 years. You might well get a rap over the knuckles the first time and be told how you can improve. I don't think the regulators out there to lock us up. In fact, there's just not enough of us. So I would guess that it's best that we all pull in the same direction.
Thanks, Dr. Behrman. I think there's two other questions for you, but I just want to ask Dr. Krause first for time purposes. Dr. Krause, just a question. What advice would you give us in how to approach the discussion of palliative care? Because we often find it quite difficult to I think, approach these patients from an emotional point of view.
Thanks, Dr. Naidu. I think when we approach patients in hospital, it's first about building rapport and saying, especially when our palliative care team comes to the patients, sort of introducing us as just an extra layer of support. And I must tell you, most patients are very eager to get that extra layer of support and just to have someone come and talk to them. And before you use the word palliative care, actually find out how they understand their own illness and where they are at with their own illness before you use the word palliative care. But most of the times, I can tell you, patients are so eager to talk and for that extra layer of support that they're quite happy to receive that.
Thank you so much. Just one question for Dr. Nel as well. Based on our stats of long COVID in South Africa, we seem to be behind our first world composites, in the Europe and US. Is that just because of underreporting or genetic predisposition? Just your thoughts.
Yeah, it's a really interesting question. We don't know yet. There is some work at the NICD and by other groups to look at long COVID in the country. It does seem like our population's perhaps a little bit more stoic and less likely to report problems. Whether or not they're there or not, though, is a separate issue. And certainly even in South Africa, regardless, it's a big enough problem, that if you phone, as for example, the NICD did phone people prospectively after they've had COVID and been in hospital and follow them up, a substantial proportion of those people are still having issues. It is for whatever it's, for whatever the cause is and however much of that's related specifically to COVID versus just a generalized issue of being unwell and then the sequelae of that. It is a profound problem, at least for several months afterwards. And I do think it needs to be factored in, let's say, in terms of this, because, for example, if you're an employer who has employees with this sort of condition, it will take some time for them to get back potentially to normal. We've had people even triple vaccinated and rest getting, often saying, well, my memory's not, for example, what it was, a month ago. It does get better with time. Almost always it's really, it will get better, but there's a lot, even in South Africa. But you're right, we don't have a lot of data here. We've got some, but there's almost nothing from low and middle income settings. South Africa, in fact, punches well above its weight in that regard. But it's a big problem, and we may find out more down the line only, sadly. Thanks.
Thank you so much. I think that leaves us with 5 minutes left, and there's 2 questions left for Tony, if you're willing to take them on, from Dr. Clara. How then should public health institutions best handle patients' personal information in research studies and quality improvement projects? That's the first one.
Yeah, super. So from a data collection point of view, it depends on if the patient is giving consent for additional processing. And it was one of the Magnificent Seven that I was talking about there. If you have not taken additional consent for processing, then obviously you would try and anonymize the data as best as you can. The anonymity of the data and the process of anonymization is a gray area, because there are certain instances where you attempt to anonymize, but you can, through reverse engineering, actually find out who the data subjects were. And once that happens, then you've breached the patient's confidentiality. So the gold standard there would be when the patients join, or where they come into the public hospital and they get their folder open, that this is included, and that it's not included as a blanket, but should further information be needed for processing, that they give consent to it, but that they will be contacted and they would be explained for what the data is to be used for, and then they would be asked, are you still happy with that? So again, it's the reasonable approach. There is no blanket approach as far as POPIA is concerned.
Excellent. And
that answers Clara's question.
Yes, I think it does. And the final question for you, Doc, from Dr. Gassner: what happens in the case of children and parents where giving information to the parent is of benefit to the child's health management?
Yeah, certainly. So I think here you've got to look at the different cut-off points where a child is deemed to be entitled to accept or refuse treatment, and then to look at the general rule as to when you become a major and for how long your folders must be kept. And we touched on that yesterday as well. But just a rule of thumb is under the age of 12, the parents remain the first point of contact for children. So parents calling in and asking, a child has been burnt, how is the child? That would be deemed to be in the child's best interests. The multidisciplinary team would be functioning around that, and the parent would in fact be seen as part of the MDT because of the need for support and succor and all of those kind of things, obviously with cleanliness and hygiene being taken into paramount account. Then if we look at somebody who falls pregnant under the age of 16, then in fact the law, I think I'm correct, I haven't looked at this for a while, but the law actually indicates that that individual is entitled to request a termination of pregnancy irrespective of their age, and that TOP, that procedure is it's entitled that female does not share that information with anybody. Now, I know that there were a lot of caveats around that by trying to explain how difficult it is to accept that kind of step that you're going to take, and the fact that one would need a patient or a parent or a guardian to help you along the way. But the raw base of the law actually says that they don't have to, and we must always be extremely careful on paternalism. So we would attempt as best as we could to say, have you got somebody who is going to be able to help you with this, maybe explain it a bit more, make sure that you're using the correct terminology that a child would understand, make sure that you've covered things like ethnic, religious, cultural, language, all of those kind of things. So that's from a child under 12. Over 12, children are entitled to accept medical treatment without parental control. So over 12, a child can say, no, I want, or yes, I will accept. The kind of question mark there always is, but who ends up paying the bill? Because if it goes to a medical aid, they don't maintain that patient's confidentiality. But the law says over 12, a patient, a child, can accept medical treatment without parental consent. And then over 16, I think it was, and I need to look this up. I last looked at this a good while ago, but I think it was over 16. The child can consent to both medical and surgical treatment with full confidentiality. And again, MDT and parents, etc. One always assumes that the parents are there for the best interests of the child, and only the history that is pertaining to that case will confirm whether those parents are actually maleficent or whether they're beneficent. And then the last would be just again to make quite sure we don't misunderstand the destruction of records. Children's records should be kept until the age of 18+3, as should mentally challenged patients. But for the rest, the 6 years, yes, 6 years, no, apply. And I think we went into that yesterday.
Thank you so much, Tony. I think it's now 10:46 and we've reached the end of our session. It's just left to me to thank all our speakers for a really engaging and excellent session this morning. I've learned a lot personally, and I think it's now due for a break and to reconvene in the 5th session, the positive ways forward for healthcare post-pandemic at 11. So thank you once again.
Thank you.
Yes.
With over 750 patients being treated at any one time, we are reimagining healthcare to bring you South Africa's largest virtual hospital.
It was advisable for me to be hospitalized at home.
So I was so scared to go to hospital.
I mean, the comfort of being at home, of course, is first and foremost.
Yeah, at home, it worked wonders.
Discovery Health Hospital at home. Connect to quality hospital-level care in the comfort of your home through cutting-edge digital healthcare technology.
This little device that they attach on my chest.
It was just brilliant. It was comfortable. It was easy.
Rest assured at home with round-the-clock remote monitoring.
I would be woken up at night because my temperature was spiking.
A clinical care team is on hand 24/7 to check your vitals in real time.
Like they would also call me on a daily basis.
I found the experience very good, professional, the attention to detail.
With a focus on recovery, our supportive services offer medicine and food delivered conveniently to your door.
I felt like I was in very good care. They know exactly what they're basically doing.
Connect with your doctors daily via virtual ward rounds.
The platform has been extremely useful to engage with our patients.
They would always call me in the morning to find out how am I, what.
Your personalized care team is our priority to meet all your medical needs.
Even having blood drawn, that was done from the comfort of my bed.
Because I felt like I was getting Rolls-Royce treatment, and I said,
and when you need hospital-level interventions, we'll bring them to you. Healthcare professionals are on hand for home visits for your complete peace of mind.
Absolutely, first world-class care.
Connected, convenient, complete care for your hospital stay at home. Hospital at Home, Discovery Health. Reimagining healthcare. How are you today, Doctor? Well? Well, you will be now with Vitality Active Rewards for doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have Discovery qualifying products or not. And it's for doctors in every healthcare setting. We know you go the extra mile for your patients, and that's why we're giving you extra Discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more Discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors. for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for Doctors today.
Speculation has been about exactly what the president will announce. Will we descend down to alert level 2, and with it, what are the stipulations, all of that?
Because of you.
I fear less.
I hurt less.
Because of you, I'm back at work.
I'm playing with my children. And our days can begin to feel normal again.
Because of you,
I know the true meaning of leadership.
Of courage.
Of love.
And I see what it means.
To truly sacrifice.
All because of you.
To all our frontline healthcare workers.
Siyabonga.
Dankie.
Enkosi. Thank you.
How are you today, Doctor? Well? Well, you will be now with Vitality Active Rewards for Doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for Doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have Discovery qualifying products or not. And it's for doctors in every healthcare setting. You go the extra mile for your patients, and that's why we're giving you extra discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for Doctors today.
Welcome back. We're just handing over again to the CEO of SOMA, Dr. Busimusi Mhlophe.
Renir, good session that we've had in the last, session, and thank you so much for all the participants in that session. We now go on to the next session, which is sponsored by Discovery. I have Mr. Darren Sweden joining me as a facilitator, but since that the compiling of the program, Darren's responsibility has been incredibly extended. He's got broad shoulders, so he will be assisting us with all the questions after the presentation. A little bit about Darren. He's head of health professional unit at Discovery and has been with the organization for quite some time. So what we will be doing is going to all the presentations. I will introduce the speakers. We will play the videos back to back. And if colleagues could please put their questions in the Q&A, and Darren will be able to assist us with those at the end of the presentations. So we have 3 presentations from Discovery. The first one will be by Dr. R Whelan, who is the Chief Commercial Officer at Discovery. Ron is a medical doctor by training, but also has an MBA. Before joining Discovery, he was an associate at McKinsey from 2006 to 2013. It was during this time that he co-led the McKinsey healthcare practice across the sub-Saharan Africa. Additional position that Ron has occupied, he was a partner and head of healthcare investments at Spinnaker Growth Partners. The significant role that he has played in this position is that he was responsible for a range of healthcare ventures and was the founder of HealthForce, a leading telemedicine player in South Africa. As you can see, Ron has extensive experience in clinical and corporate healthcare spanning more than 20 years and covering 25 countries globally. That will be the first video that you'll be seeing. If you have any questions, please put them on the Q&A. The next presentation will be by Ms. Nonku Pitje, General Manager at Discovery Health as well. He heads the Employee Health Solutions and a group strategic client investment. Nkuli has been with Discovery for 15 years and has held a number of leadership roles, including being the service executive, head of functional operations, and head of the Discovery Health People. Nkuli joined Discovery from Accenture and has worked in management and strategic consultancy positions for a number of businesses. Currently, she leads 2 portfolios for the business, and that is Head of Employee Health Solutions and Group Strategic Clients. The last presentation will be from Dr. Anna Endres. Anna is currently the head of Discovery Health Care Services, the Service Lab and Special Project Unit, which together employs over 200 people. Anna joined Discovery in 2010 as an executive associate for, at the time, the Discovery Chief Operations Officer, Dr. Ryan Noach, and together they formed the Special Projects Unit, where several new initiatives were developed, and these would include projects like the MedExpress, Health ID, telemetry, and Dr. Connect. Anna has a graduate degree in chemical engineering from IST, that is in Portugal, and an MBA from the IESE from Spain, fluent in a number of international languages. So we will then go on to the videos at this point in time. And again, Darren will be ready to take any questions once those have been played.
Hi, everyone. Dr. R Whelan here. I'm Chief Commercial Officer at Discovery Health. Delighted to be joining you today at the SOMA conference. I'm sorry I couldn't join you in person, and I'm joining you digitally. I promise to be at the next conference in person. I'm going to share some insights today around the South Africa landscape, and particularly the healthcare landscape in South Africa, some reflections from our side. And then as a second topic, we thought it might be useful to share some reflections on what the medical practice of the future could look like. We've done some work in South Africa and some work globally, and we are seeing some patterns and trends emerge from that work. I think the first thing to note in South Africa at the moment is that we are obviously facing some significant headwinds, both from a country perspective as well as from a health system perspective. The first headwind is obviously inflation. We've seen the petrol price increase, and as a result of petrol price increases, we're starting to see inflation in food, in various retail goods, and various services. And this is certainly placing significant pressure on the South African economy and the South African consumer, and will undoubtedly impact the other healthcare landscape as well. Secondly, we're in a very tough position when it comes to energy in South Africa, as we're all well aware of, with significant load shedding over the last few months, and no clear trajectory on improvements in the energy situation in South Africa. We're certainly hopeful that it gets resolved over the next few years, but this is impacting our personal lives as well as our professional lives and our working environments. Thirdly, South Africa certainly feels a little bit like it's on the edge at the moment. There's significant political and social instability. This particular picture was from just over a year ago in KZN. Where we're all well aware of the riots that happened during the course of July last year. Subsequent to the riots, we obviously saw an N3 blockade during the course of 2022, also driven by socio-political unrest. And then we're seeing socio-political unrest across various municipalities across the country as well. Fourthly, from a health system perspective, and coming through the COVID-19 pandemic, we're facing a healthcare sector and healthcare workers that are exhausted. It's been a tumultuous time. You've all been on the front line in responding to COVID, and I do want to take a moment to say thank you for all of the work you've done during COVID. Healthcare workers have done phenomenal work. Many lives have been saved as a result of your endeavors during the last two years or so, and I think it's really demonstrated the capability of our doctors and healthcare professionals across South Africa. Despite significant waves of infection, the health system did not collapse. And I think that is really testimony to the strength of the healthcare system, and most particularly the capabilities, leadership, and commitment of healthcare professionals across the system. Alongside this, we're obviously facing healthcare worker shortages, both in the public sector and in the private sector, and significant work needs to be done on addressing those shortages. Then, of course, we're seeing immigration across the country, including across the healthcare sector. And this is a concerning pattern and trend for all of us across the country, and something that is becoming a real headwind from a healthcare sector perspective as well. And then finally, we obviously have a big debate in South Africa around national health insurance. I think we all agree that we need to get to a position of universal healthcare coverage across South Africa. We need to have a more equitable system, and we need to have more equitable access to high quality healthcare across the system. The NHI discussion is one of the mechanisms for achieving that universal healthcare coverage. It is a very complex implementation process. It's resulted in a lot of uncertainty across the system, which we're all feeling, but it's certainly adding to some of the uncertainty and headwinds we're facing as a country, notwithstanding the fact that we absolutely have to find the right pathway towards universal healthcare coverage across the country. Then on the flip side, I think it is important to point out, when you step away from the noise, there are significant tailwinds and positives across the landscape. And these are not always easy to see against the backdrop of some of the headwinds that we're facing at the moment. The first tailwind to note, and I think you would all acknowledge this, is that COVID has resulted in a massive acceleration in the adoption of digital technologies across the healthcare system in South Africa and more broadly. And I think those digital technologies have always been in the environment, but COVID has really accelerated that adoption. And that's a very exciting space to be, because the technology is now ready for widespread delivery of healthcare services. There is good evidence around the technologies that are emerging, and lots of data to support these technologies. And then I think really importantly, the technologies are becoming a lot easier to use. So the particular picture you see in front of you, I think, is becoming less science fiction now and much more reality. All of these elements on this particular picture are readily doable, and we're seeing examples of this across the South African landscape already. It's interesting to note the adoption of telehealth, both globally and in South Africa. So this is a recent study by the American Medical Association of just over 2,000 doctors in the US, showing 85% of doctors now using telehealth in the US. That's just a startling number. In addition to that, and I think that this is a really interesting stat, 64% of doctors doing telehealth from home. So doctors have changed their offices from practices to home offices. It's opening up additional access to doctors. It's opening up additional revenue streams. So a very interesting finding in my view from this particular study. But then the most interesting finding for me out of this study was that 21% of doctors are now seeing 80% of their patients through telehealth. Think about that for a second. Across this constellation of 2,200 odd doctors, over 400 of them see 80% of their patients through telehealth modes. And think of that implication on your particular practice. It's really a massive landscape shift. And then 68% of doctors now seeing their chronic patients through telehealth. So certainly seeing a much broader adoption of telehealth into some exciting areas. The second tailwind that I think is worth noting in South Africa, it's often hard to see this from all of the rest of the noise across the landscape, is that we have much higher uptake of bank accounts across South Africa, and therefore financial literacy, therefore different payment mechanisms across a broader cross-section of the population. So if you look at this particular chart, back in 2010, just over 50% of the population in South Africa had bank accounts. Now cast your eye to the right-hand side of this chart, and you'll notice that around 2021 and 2022, in the order of 81 to 84% of people had bank accounts. Just think about that for a second. So bank account penetration, 30% more people in South Africa now have access to bank accounts. There's certainly access to funds across those bank accounts. I think this is a real tailwind for the healthcare sector across South Africa, and the ability for consumers to pay for some level of healthcare services. Thirdly, through COVID and before COVID, I think I've recognized that we just have amazing talent and capability across South Africa's healthcare sector. Brilliant scientists and brilliant doctors. Top left-hand side of the picture, you'll recognize Prof. Glenn de Grey, who's been a preeminent leader in South Africa's COVID response, but also a global leader in the COVID response globally. He's actually an advisor to the US around COVID-19, meets with the White House on a regular basis around COVID-19, and indeed many European countries. Bottom left-hand corner, you'll recognize Martin Sussman, a cardiothoracic surgeon out of Milpark. Martin and the team at Milpark just did astounding work through COVID. One of the few units across the country and indeed globally with fully fledged ECMO, had some of the best ECMO outcomes across the world. That's the capability that we have in the healthcare system. Top middle of the picture, Professor Zebron Vilakazi, who's the Vice Chancellor of the University of Witwatersrand, recently inducted into the Royal Society in the UK. The Royal Society in the UK is an esteemed group of astrophysicists and nuclear physicists, and counts amongst its members Isaac Newton, Albert Einstein, Stephen Hawking, and so on and so forth. This is the caliber of the scientists and academic we have in the country. You'll recognize Professor Salim Abdul Karim. You'll recognize Dr. Kelly. They're recently acknowledged by Harvard as the top, in the top 25 public health scientists across Africa. Bottom right-hand picture, you'll recognize Guy Richards. Guy Richards was really led the way around some of the initial COVID treatments, high flow oxygen as an example. It was one of the first units globally to use dexamethasone therapy all the way back to April, May of 2020. And then, of course, you've got the Vice Chancellor of the UCT, who's just doing amazing work at UCT at the moment as well. So leading scientists globally. And then, of course, we have world-class facilities across the country, very sophisticated hospitals with very sophisticated technology. We continue to build new and state-of-the-art hospitals. And I think, once again, a very important asset for South Africa's healthcare system. We see a similar set of assets across the primary healthcare infrastructure as well. And this is certainly a tailwind in South Africa's favor. And then, of course, when you look across the landscape, we see a number of emerging leaders coming to the fore, starting to be more vocal around transformation across the healthcare system. I think it's our obligation to find these emerging leaders, grow these emerging leaders, support them over time. This is really the future of healthcare in the country. And then, of course, what we saw coming through COVID was tremendous collaborative leadership in the COVID-19 response. We saw public-private collaboration from the senior levels in the response, a coordinated effort by both the public and private sector in responding to COVID. We saw public-private partnerships happen at hospital level in the response to COVID. We saw the vaccination program, which in many respects was a public-private partnerships, allowing uninsured members of the population to access vaccination in private sites. We saw medical aid members going into public sites for vaccination. And I think a clear demonstration of what can be done if we see collaboration across the public sector and the private sector, joining forces around a single goal. And I'm hoping we can use that as a foundation to really shape the future of South Africa's healthcare system. So to sum up, these are the main tailwinds, and the question for us as a group, and the question for us as doctors and healthcare professionals across the South African landscape is how do we capitalize on some of these tailwinds? Digital health delivery is a real opportunity to make care more accessible and more efficient. We have a rapidly growing aspirational market who has access to bank accounts and payment mechanisms and is seeking high quality and affordable care that is convenient to access. We've got world-class talent and facilities across the landscape. How do we leverage that talent and facilities in the best interest of the entire population? We've got an inspiring crop of emerging healthcare leaders that we need to grow and support. And then, of course, as I mentioned on the previous slide, we've got a real foundation around leadership collaboration that we need to continue to build on going forward. So what will medical practice of the future look like? And the reason we think that this is important is that each and every single medical practice across South Africa makes a contribution towards the overall evolution of the healthcare system. We coalesce that and we build a stronger, more robust, and more sophisticated healthcare system going forward. So we see a few components to the practice of the future. The first one is no surprises. We see a big digitization trend across practices coming forward, and I'll speak about some of the elements of that digitization play in a little bit. Secondly, we think that medical practice of the future need to take a much broader aperture to the population in South Africa. While we've got 9 million people on medical aid coverage, we've got a population of 60 million that we need to serve, and we've got to take a much broader approach to providing access across the population. Thirdly, population health management is becoming an important trend both globally and in South Africa. So the question is, how do practices look at specific populations? And what that really means is looking at your population living with diabetes, looking at your population living with cardiovascular disease, looking at mental health population across your practice, establishing systems, processes, multidisciplinary teams around those particular populations. So in addition to you're looking at your practice through an individual patient lens, also look at your practice through a population health lens. Then, of course, point number 4 is data-driven decision-making. There is significant work around collating data now, and various elements of data, various data sets available. It's a question of turning those data sets into insights and turning those insights into actions. And we can certainly do that at a practice level nowadays with the tools available. Value-based care is a massive trend globally. South Africa is seeing significant momentum on the value-based care front. And I think this is an exciting and an important opportunity in our development of South Africa's healthcare system. We have to move into a space where we are focused more on outcomes. We're focused on value units. We can't continue to be an input-driven system. We really need to focus on outputs and outcomes, and value-based care is one of the tools to get us there. And then finally, there's significant work that needs to be done around seamless funding and payments. And seamless funding and payments really opens up access to a broader cross-section of the population across medical practices. So we feel quite passionately about seamless funding and payments at Discovery. There are many other players in the market there. And I think on the back of the bank account uptake in South Africa, this is an important development for practices of the future. So let me dive into a little bit more detail, just to give you a bit more color around some of these elements. The first one is the digital practice, and what we see as the main components for a digital practice. The first main component is a digital booking capability. Digital booking capabilities are critical because consumers look to book consultations as they seek to do online shopping and online deliveries. They seek to book consultations online. So it's an important portal for consumers to access healthcare practices. In addition to that, I think digital booking will become increasingly important going forward as you run a hybrid practice. A hybrid practice means that you're going to see some of your patients in person in your practice, and you're going to see some of your patients via telehealth where applicable. And having that digital booking platform allows you to run a hybrid calendar where part of your appointments are virtual, part of your appointments are physical appointments. Is a seamless inflow of those appointments and adjusting those appointments on an electronic basis. So virtual consultations is certainly going to become mainstream. I'm sure most of you already do virtual consultations. The technology has evolved rapidly. In addition, there's good clinical evidence around the safety and efficacy of virtual consultations and telehealth. So an ongoing evolving landscape there. Hospital at home, we saw coming through COVID the need for more advanced care at home protocols. We obviously needed the additional hospital capacity coming through the different COVID waves. Providing hospital services in a home environment allowed to relieve some of the burden on the healthcare system. We're now seeing evidence globally that hospital at home models providing equivalent and sometimes better clinical outcomes than actual hospital environments. And then they obviously come with the added benefits of lower hospital-acquired infections, lower risk of thromboses as a result of immobility, better nutrition, better sleep patterns, less falls, and so on and so forth. So I think that is really becoming a model for the future. There's also, incidentally, a capital-light model for us to build additional hospital bed capacity across SA. Point-of-care pathology is another exciting space. The technology is now developed to such an extent that 60% of blood tests can be conducted on a point-of-care device. It continues to expand quickly, and it's quite conceivable to see that over 80% of blood tests will be done on a point-of-care device over the next few years, providing equivalent quality to regular lab-based testing. And then the fifth category around the digital practice is we're seeing rapid evolution of digital therapeutics. Digital therapeutics are a proliferation of clinical apps. Some in the diabetes space, some in the cardiovascular space, some in the weight loss space, some in the mental health space. And these apps are starting to demonstrate that it is possible to improve clinical outcomes through digital means and sophisticated science and algorithms around these applications. So it's conceivable over the next few years, you are going to be prescribing digital apps as part of your treatment modes for your patients going forward. Moving on to the next section, I think just to share with you what South Africa's population distribution and demographics look like. We're obviously on the left-hand side of the picture. You'll notice there that there are somewhere around 6 million civil servants in South Africa, formerly employed in the civil sector or the public sector. In the large formal sector, employees are about 12 million. Smaller formal sector employees are about 6 million. And then about 11 million people employed in the informal sector. And then, of course, I think sadly to point out, and very unfortunately, a big problem for us to solve in South Africa is 25 million people, unfortunately, unemployed across South Africa. These population groups access healthcare in different ways and access healthcare financing in different ways. 9 million people on medical aid coverage, primarily out of civil society as well as through the large formal sector employees. 25 million people largely on social grants accessing care through the public sector. And then a big cross-section of the population in the middle, somewhere in the order of 26 million people employed in some shape or form, large employers, small employers, and then across the informal sector. Out of those 26 million people in the middle there, we estimate that somewhere around 12 million people could afford some level of health insurance coverage. And health insurance coverage allows them to access high quality healthcare across the system. It also provides them with a solid safety net in the event of catastrophic healthcare expenditure. And then, of course, we've got to find a solution for the balance of that population, so the further 14 million people in that population. But I think what's important around this particular slide is, as a healthcare sector in South Africa, our obligation is to provide the highest quality care across the entire cross-section of the population. We're just going to have to find different financing mechanisms and means across the population. We're also going to have to think hard about the type of delivery models. But we all have a role to play in making sure that everyone across South Africa has access to the highest quality healthcare. Population health management, I'll speak about very briefly, just to share with you what we're doing from a Discovery Health perspective on population health management. So we have just short of 750,000 people across Discovery Health who are registered for a chronic condition: diabetes, mental health, oncology, cardiovascular disease. And roughly 300,000 of those 740,000 members are on one of the population health management programs. And what that allows us to do is to manage the different risks and needs of that population, as you'll see there in the pyramid chart and the pyramid diagram in the middle of the chart. And then on the right-hand side of the picture, you'll see the different population health programs. So from a practice management perspective, I think it's important that you've got a view. What does your population look like? Is it primarily a diabetes population or cardiovascular population? Potentially it's a mental health population, potentially an oncology population, so that you've got a holistic perspective and are able to provide those populations with the right level of care at the right time. And then I think just some thoughts around data-driven decision-making. The way we think about data is that there is clinical data, as illustrated on the left-hand side of this page, and there's financial and operational data, as illustrated on the right-hand side of the page. The clinical data, I think, is important to point out that it's both patient-specific data as well as practice population data, as well as clinical outcomes data. So it's a much broader set of data than what you would traditionally think about. Typically, we think about individual patient data. But if you take the population health management strategy that I spoke about on the previous page, now that population health data is equally important. And then on the right-hand side of the picture, the financial and operational data for your practice is absolutely critical. We need practices that are efficient and financially sustainable. So focusing on things like practice income and revenue cycle management, focusing on operating performance metrics across your practice, and then of course the value-based care outcomes is absolutely important. How does data manifest across practices? So I just wanted to share with you a high-level population health management dashboard. You'll see it on the left-hand side of the page. It basically says, here is the entire, in this particular example, the diabetes population that's on this program. It gives you a sense on the disease stage distribution of that population, as illustrated in those bar charts there. It gives you a sense on, in this particular example, HbA1c testing rates in that little donut diagram on the left-hand side of the picture. Yeah, you can see very clearly and easily that 80% of or 79% of this particular population had an HbA1c test in the last 6 months. And then on the right-hand side donut, you'll see there the proportion of those tests that were in range or out of range from an HbA1c perspective. So a very powerful way of illustrating the health of an overall population, and allows you then to double click onto how do you improve the particular outcomes across particular subsegments of that population. Just a few thoughts on value-based care. I think the high level message around value-based care is there's extensive work happening in South Africa on value-based care. Across Discovery Health, we have a range of value-based care tools and assets. But I think the most important point to make on this particular slide is you look at the top right-hand point there. South Africa as a whole is making good progress on the value-based care front. So in the US, about 20 to 25% of the overall health system expenditure is in value-based care agreements. Across Discovery Health in South Africa, about 30 to 40% of healthcare expenditures in value-based care agreements. And that is important because it means we're focusing on clinical outcomes. It means we're focusing on cost efficiencies. It means that we're building a strong healthcare system for the future. And then finally, just some thoughts around seamless funding and payments. This is very much a Discovery example. To illustrate some of the examples, is a primary care insurance product for those clients that can't afford full medical aid cover. There's a prepaid product that provides pay-per-use access to high-quality and affordable treatment. Really opens up a different market segment for medical practices across the country. You're well aware of the gap cover product. And then we've recently launched a health pay solution. Health pay solution allows for instantaneous payment of healthcare expenditure. So it means that the practice is guaranteed payment immediately, and we sort out the different financial recons in the background. Powerful mechanism for practices to secure payment, powerful mechanism for patients to access care when they need it most. So to wrap that up, 6 main components as we see it for the practice of the future. There are, of course, other components that also need to be implemented, but we see these as the 6 main, capitalizing on some of the tailwinds across the marketplace, various tools and assets already in place, various practices making significant inroads into implementing the various initiatives around practice of the future. So quite an exciting terrain. With that, I want to leave you with a positive message that despite some of the headwinds we're facing, there are significant elements in our favor. And I think there's a lot of movement on the ground towards crafting the practice of the future. And I wish you a very successful conference, and we look forward to continue to work alongside you and collaborating with you to build South Africa's healthcare system of the future. Thank you very much.
Good morning, everyone. My name is Pitje. I'm the Chief Growth Officer at Discovery Health, and it's a real privilege to be talking to you today. The topic that I'm going to be talking to you about is one that I'm really passionate about. It is the opportunity to expand quality, affordable healthcare to millions more in this country. And I believe this is a very important topic and a very important issue that touches all of us. I'm privileged that I sit as part of the Discovery Health Executive Committee, as well as the Discovery Health Board. And the reason for that is that as part of those forums, we have made a decision that one of the key things we want to do and the legacy we want to leave is really this idea of expanding healthcare, using all of the capabilities that we built in this business for the past many years to expand healthcare to millions more in the country. You will see on the left-hand side of my screen that the first thing it says at the top is it talks about the aspirational market, because we aspire to provide quality healthcare solution to this market. You will hear in many places that some people call it the emerging market, the main market, but we thought the aspirational market really captures our intent in terms of the market. Our vision as a health executive committee is very simple. It is to build high quality, simple, relevant, and dependable healthcare solutions that are close to home. We have agonized over this vision, and the reason for that is we wanted to make sure that it delivers what is most important and critical in this particular market. Our bold ambition, which I am very proud of and really driving hard to be able to achieve, is that we want to expand healthcare or access to private quality healthcare to an additional 1 million people by 2025. I'm hoping to talk to you on 3 key topics today. The first one being really, if we look at the market today, how does the South African medical insurance market look like and what are its characteristics? Then I want us to segue into the evolution and what we see in globally in terms of global best practice. And then finally, really what the opportunity is in terms of how we play and we expand within this ecosystem. If we then maybe segue into the first topic, it is important to just really understand what the landscape looks like. In this country, there are about 60 million people. Of those 60 million people, we have between 8.5 and 9 million people that are really covered in medical aids or have medical scheme cover. We also approximate that there's an additional 500,000 people that either have health insurance or are relying on other healthcare capabilities that are outside of what the state offers. What that leaves is just a little more than 50 million people that have to today rely on an overburdened state capability. We've then looked at that 50 million and we really wanted to understand where we could make a difference, especially those of us that play within the private sector. And in that 50 million, what we see is that there's just under 13 million people with disposable income that today are uninsured, but are trying to access different healthcare solutions and don't know that they're healthcare solutions that are right for them. And we think that's really the market for us to focus on. If you take this one step further, and this is an important step in further sort of breaking up the demographics, what you'll see is that 70% of the South African consumers within this market in the households earn 6,000 rands or under. So when we think about solving for this market and really providing access, we need to think about what is affordable. The next breakdown, which is an interesting breakdown, is I talked of the 13 million or just under 13 million people. If you look at the breakdown there, working with me from left to right, you'll see that about 9 million people access healthcare because healthcare is shared. That's also an important concept in the aspirational market. What we see is that families live together and usually need or have a need to share healthcare. So when we're thinking about solutions, we can't think about solutions that are one-to-one basis. We need to think about solutions in that market that can be shared. Then when you walk with me to the middle part, what you'll see is that we have full-time and part-time employed people. They're making about 3 million of a cohort. Those particular people are either today buying health insurance of some sort or being supported either by the employer who subsidizes healthcare. And again, we need to wear a different lens in terms of how we support them. If you look at the regional breakdown, what is really opportunistic and quite encouraging is that we can see that there are particular areas that have densely populated target market that we need to look at. You look at Gauteng, you look at KwaZulu-Natal, you look at Western Cape, and that's the biggest opportunity in terms of the growth that we're looking at and the access into healthcare. We also know in terms of the age group, the 18 to 34-year-olds represent a significant opportunity. Those are people that are upwardly mobile, that also have mobile technology that we can use as we think about this expansion. If you look at the demographics in terms of color, we've got Black African people making up about 85% of this population, followed by colored people. So we have a pretty good picture of where we need to focus, what is the affordability threshold, and what we need to be looking at. Internally in Discovery, we've taken this one step further because we think it's really important to further understand the segment. So we've divided it and given it a flavor in terms of some of the personas that exist in this market. So if you go with me to this, let's start with Zanele. I'm introducing you to Zanele. Zanele is married. Zanele has a spouse and also has 3 children. In terms of their household, they're able to gather from both the man and the woman in the family an income of about 8,000 rands. Like you and me, Zanele is concerned about her children, about the children's education, the children's health and safety, and those are the things that are driving Zanele and her husband's choices in life. So one needs to think about that when they think about the segment. They want to make sure that the kids are taken care of, both from an education perspective, but healthcare is an important part of that. Then we have Thabiso. I personally love Thabiso. Thabiso is young. Thabiso is completely obsessed and thinking about how does he change the trajectory of his family and their life and their livelihoods. So really what he's focused on is, how can I help my mother in order for my mother to support my siblings and take us into, hopefully in the future, a new way of living. And so he's focused on his education, driving that hard, accessing educational grants, educational bursaries, etc. Thabiso also works on a part-time basis and can only afford healthcare as and when the need arises. And in the main, he's not worried about his own healthcare needs. He's worried about his mother, who has a chronic illness, and therefore from time to time, he needs to support that need. And then finally, meet with me, Bra Lufuno. Bra Lufuno has worked all of his life. He's really looking forward to retirement. His kids are in the part of their lives where they're starting to make their own livelihoods and are able to support themselves. But Bra Lufuno has chronic conditions and his own healthcare needs are important. He has disposable income on an ongoing basis because he's a contractor, but also has worked a lot of his life. So if you look at the range of needs here, you have parents at almost a start of their lives. They have young kids that they are raising, and they probably want more certainty and ongoing healthcare. So when you think about it, probably some kind of health insurance works in that space. If you think about Thabiso, Thabiso is concerned about, in his mind, bigger things, education, changing trajectory, but as and when the need arises, particularly based on his loved ones, he would like to get healthcare and share healthcare with the right loved ones. And then if you look at Bra Lufuno, he's really concerned about, how do I keep myself well and how do I keep myself safe? At the bottom of the slide, what is interesting, what you'll be able to see is the disposable income that is available means that there's a price ladder and a price threshold that people can afford. From Zanele and her family, who can afford about 914 rands in terms of disposable income, Thabiso between 150 and 300 rands, and then Bra Lufuno 385 rands. Critical data points that allow us to think of solutions that are meaningful and useful to people in this space. Then another important input that we should pause out for a moment is what we know. Research tells us, and we've done research really broadly, but research tells us that healthcare is important in this segment of the market. In fact, it is number 4, as you can see on the left-hand side, and insurance is deemed as number 5 after transport, housing, and food. And this is understandable. This is where we live. You know, transport gets you to work, housing and food is for you to be sustained, and after that you can think about other needs. But the fact that it is part of the top 5 needs is critical and means that there's an opportunity for us to think about it, solve for it, and make an impactful difference. On the right-hand side, what is really interesting is what people believe is available right now. We know from the market, and we know with research we've done with people that we've looked after within the primary healthcare perspective who have lower incomes, is that one, people believe that insurance is very expensive and therefore it's not for them. And insurance today is only seen with the hat of medical aid and not understanding that there could be other solutions. The second thing is that insurance is confusing, that there are lots of T's and C's, and in fact, what I see is not what I get. And then finally, there's this underlying sort of feeling amongst people in the aspirational market that health insurance providers are dishonest. And this comes because people say, I go into the system and then for some reason, there's out-of-pocket expenses that I didn't plan for while I thought I have some kind of insurance product that looks after me. So in building these solutions and how we think about these solutions, critical is we make sure that we understand the voice of the customer and that the solution mitigate against those things that people are concerned about. I wanted to tell an anecdotal story before I go on to the next slide. When we started in the primary healthcare space a while ago, and we're working with employers to be able to provide primary healthcare for their employees and to be able to subsidize it, one of the decisions we made was that we were not going to have cards, almost like the card that you identify yourself with when you get to the doctor. We built a system and we worked with providers so that people can arrive at the doctor's rooms with their ID book, and then the practice manager could put in the ID number and then see that they're a primary care member that's being looked after by Discovery, provide them with the relevant treatment. What transpired then is that people didn't use the medical insurance product that is provided to them. We couldn't understand this. So when we built the product, we did this because we wanted to get the product as efficient as possible to save on the cost so that we can make the pricing as sharply priced as possible and as affordable as possible. So taking away sort of the loading on the card and making sure we can make the product cheaper rather, and then working with the providers to make it a seamless process. The people who received this and were using it, as an example, there were people in the trucking fraternity, and they said, you know what, I don't want to go there with my overalls and then say to them, please take my ID. Because I've never used a doctor in the private healthcare system before, I feel like they won't see me. Basically, people felt like they were not legitimate in the system. Those are some of the learnings we had to go through. And then we actually went back and we created the card because that was such an important barrier to entry that we needed to remove it. So the voice of the customer remains critical and something that we have to refine and look at all the time. So let's maybe go very quickly into what we see that is happening from a global best practice perspective and how people are changing how they look at and think about healthcare and how they're creating access for millions more. I'll start with the first example, a fascinating case study that is born out of India called Hello Life CX. This actually is a solution that is really focused in rural India. It is a digital solution, but what is interesting is it's in a community that doesn't have digital access and actually where mobile is not ubiquitous. So these are, if you thought about it like a box type of solution where it is small practices, it can be done within 4 hours. They are available and they're meant by a nurse. They're supported through telemedicine and virtual consultation where a doctor is required. There are only 64 square feet, which is in meters, as you know, is close to about 6 square meters. So most of our bedrooms, we have the privilege here are about 6 square meters. But in that box, magic happens. So you can have a consultation through telemedicine and the ability to have virtual consult where an escalation is needed to a doctor, a consultation is done, it is scripted, and the price point is $4, akin today to probably about 70 rands if you look at the exchange rate. It is incredible how technology has been used, one, to speed up the delivery of services, to make it available anywhere in rural India, as long as there's an internet connection anywhere close by, to use to use a different resource, which is nursing, but supported very strongly with a doctor presence where it's needed, and to make sure that it's a one-stop shop. So these people have no technology, they've got no mobile of their own, but through the technology in a box, magic can happen. And this is one way that technology can be used in bringing services in a particular space. A fascinating best practice type of solution. You should actually take the time to look at it if you have the opportunity. The second example that I want to talk to you about is an example that is using mobile wallets. And why I thought this was interesting, this is a Kenyan example. Mobile wallets have become ubiquitous. People share money, send money, so people know and trust mobile wallets. The case of Mtiba, many of you'll know the case study of M-Pesa. M-Pesa is a mobile money solution in Kenya. They've done an excellent job partnering with many vendors around Kenya, where you can go to many vendors, including sort of small spaza shops or at a filling station, to be able to deposit money or get money while you send money around the Kenyan environment. They then partnered with health professionals on one end and with funders on another end. And they said, can we use the mobile wallet in order to be able to share, to purchase rather, and to be able to share consultations? This has been brilliant in this context. What they've been able to do is that they've been able to scale quickly because they partnered with M-Pesa, which many people already knew and trusted. So right now they're sitting at 4.5 million lives that are using this. They've got over 1 billion transactions that people using mobile wallets in order to buy consults, share consults, send consults to other family members. And today there are almost close to 1 million sort of treatments that have happened. This has been brilliant in the COVID times where you get funders that have been able to pay at a very fast pace, as an example, the doctors, because through mobile money, they're able to get claims quicker, pay the providers quicker, and it's also made it ubiquitous within this market. So it went from almost an unknown to everybody knows it and everybody can use it in a very meaningful way. So a case study that says, how do you take different partners that were not normally in the healthcare space? How do you bring them together, leverage the capabilities in order to make healthcare ubiquitous in a particular space? And then finally, an example that is brilliant in the Indian space as well, the largest multi-channel healthcare platform in India. This is where people are using digital already, where people are using mobile already, and mobile is ubiquitous. And you've got healthcare professionals providing 24/7 consultations, being able to script and get scripts delivered within 2 hours of your consultation. All of these examples show particular and different needs in different environments. One is a rural example. One is an example of partners using mobile wallets in order to make healthcare available and easily accessible and ubiquitous in a particular environment. And the other one is using digital to make it accessible, but also scalable and efficient very quickly. And all of them were driven by healthcare professionals. Hello Life, it was started by a health professional in the Indian space. Mtiba was a partnership with health professionals as well as mobile money in the Kenyan space. And Apollo was started from the Apollo hospitals and then changed to scale in a sort of out-of-hospital capability, but again by health professionals. So really powerful opportunities for health professionals to really use different models to scale what they bring, which is a really special capability and ability of helping and healing people in different spaces. And technology, mobile wallets, and other capabilities allow us to do this. I thought a way to end is really to take us out of our comfort zone and say that today, and for many years, we've practiced in a particular way. We don't have all of the answers, but maybe if we start thinking differently, knowing what we have, knowing what the opportunities are, we could really do something special in terms of expanding healthcare to millions more. So 2 videos, please enjoy them and enjoy the rest of the conference.
Rwanda is known as the land of 1,000 hills.
It is a very difficult country in terms of topography, and many areas are hard to reach.
Traversing that terrain to get to a rural village can take hours, even though it's a very short distance.
Today, if a mother is giving birth and suffers from postpartum hemorrhaging, her life is dependent on getting a blood transfusion.
There are many different types of blood types. They have a limited shelf life. And the challenge is when you need blood, you need it immediately. But it is unpredictable which geography that will occur in.
Hospitals that are in more remote areas can have a very hard time getting enough reliably supplied blood.
The time to order and get the supplies by truck is just too late.
There's no way that we can overcome the time that it takes to get anywhere during the rainy season. And people would say, okay, during the rainy season, we're just not going to make it.
The best case scenario, it would take at least 4 hours. But with Zipline, we are looking at cutting that 4 hours to something like 15 minutes.
It is a team of Rwandese who came together with Zipline to groom the project and to make it happen in Rwanda.
Their ultimate vision is to put each and every one of those 11 million citizens within a 15 to 35-minute delivery of any essential medical product that they could need. And that's a revolutionary idea for any country in the world.
The use of drones to deliver life-saving medical products can overcome the lack of road infrastructure. We need to let our imagination soar.
When you have a commodity, rare in supply, that might be an unusual blood type or something like a rabies vaccine, and you need it immediately, the idea that we could use a drone to be able to deliver this to the country is absolutely brilliant. There's nothing else that could do that in that way.
It is like we will no longer go around hills, but we fly over the hills.
We've pulled together a team from places like Boeing, SpaceX, Google, Lockheed Martin.
And it's an honor for Zipline to partner with the government of Rwanda.
We place a hub next to an existing medical warehouse, and it instantly enables that warehouse to make hundreds of deliveries per day to any location within range.
The doctor sends us their order by text, by phone call, whatever's convenient.
Somebody identifies the need and then prepares the package, puts it on a drone.
Then we take that vehicle and we put it through pre-flight tests. It's launched, it flies automatically out to the clinic.
The path has been already calculated, it's in the computer.
And then they'll receive a text message saying, Zip is 2 minutes away, please walk outside.
It drops the packet, somebody goes and collects it.
It turns around, it flies home, and then we get it ready for the next delivery.
Our service not only makes it possible, but also affordable for countries to deliver reliable access to essential medicines for all of their citizens.
What we are looking forward to see here is saving lives.
This isn't a small step forward. This is a transformational change to how we provide medical care to people across the world.
Good morning, everyone. Great to join you in this summer conference, albeit virtually for the moment, and have the opportunity to discuss with you about improving quality access through digital health. My name is A Endres, and I'm the Chief Digital Officer at Discovery Health. And my presentation of today would like to focus on a couple of topics. So one very much around the global trends in digital applications for healthcare. And then after that, zooming in specifically on Discovery Health's digital platform strategy and the current offering that we've got. So looking at the global trends for a minute, in the last decade, we've seen really digital health platforms evolving rapidly to continuously drive better outcomes at a lower cost. And so when we look at some of the investments that have occurred in just the last year, really in 2021, it is no surprise to see that pretty much all the large insurance companies, in the US markets at least, continue to make really heavy investments in digital health. What was particularly interesting to see as well is that this acceleration in interest in the digital health space also applied to non-traditional health players. So we've seen a lot of the big tech companies to actually, and even fintech companies in the financial technology companies, to make really significant investments in the digital health sector. And obviously, you know, these big tech companies, zooming in on that a little bit, they are extremely well positioned to fundamentally transform the healthcare industry. When you consider some of the metrics that you see here around the scale that these companies have, you know, the amount of cash they've accumulated, and thus what they're doing with that cash, and the number of artificial intelligence startups that they are actually acquiring and have been acquiring in the last 10 years, you can see that they've got, you know, the right ingredients to really transform the healthcare industry as well. They've got huge client bases, you know, super recognized brands, enormous capital to fund real moonshots, and obviously to acquire a lot of companies that have developed new products. And you can see there that Apple is one of the companies that had led the pack, certainly in terms of acquisitions. To give you a sense of what they've been doing with some of these investments and where they've been you know, focusing on. I mean, just to give you a sense of some of the things they've done in the past year alone, in 2021, Amazon, for instance, launched 3 companies: Amazon Care, Amazon Pharmacy, and Amazon DX in a single year. These are all health-focused companies that Amazon launched. Looking at Apple, they also, you know, for instance, ran a pilot of having their own virtual consult subscription service called Apple Doctors. And Microsoft invested heavily, for instance, in Nuance that has developed a lot of speech analytics that support doctors in kind of capturing a lot of their notes, etc., etc. So these are just some of the examples of how these big tech and fintech companies are investing in healthcare and have done so in the last year. So in truth, the future of digital health is shaping up, you know, to look like a series of platforms formed up of traditional and non-traditional players, increasingly connected, you know, among themselves, and creating these mega platforms and entire health ecosystems with an enormous array of functionalities. And I mean, when you look at the enormous array of functionalities, this slide is actually attempting to give you a sense of the 6 big areas that we've seen, you know, from a global investment perspective that are really already, you know, parts of the digital health solutions that we've got out there. So all the way from digital health solutions around screening, diagnostics, and remote monitoring. You can see examples there of solutions that are now well entrenched in some of those journeys. Obviously, a lot around virtual consults and telemedicine. A lot of solutions also focusing on disease management and digital therapeutics, all the way from education around the conditions, but helping to manage those conditions as well. Another big area around medicine, everything from you know, management and selection of medicine, adherence, etc., etc. Then also around clinical intelligence and actually better enablement for all sorts of care teams and, you know, providers in that space, be it from the kind of the starting point of an electronic health record all the way to big population management dashboards, intelligent nudges for next best actions, etc., etc. And then last but not least, a lot of solutions also now targeting administrative automation and digitization of a lot of the processes that also happen in a practice. So, you know, scheduling, billing, etc., all of those processes increasingly have got digital and intelligence solutions for that. And so here I just wanted to give you an example to illustrate one of these trends. I mean, as these digital health ecosystems evolve and become more and more sophisticated, a big trend we've seen is that accessing all sorts of care now can be accessed from the home. And so we call this the everything at home trend, where, before we probably started from a place of having, virtual consults when, it was convenient for people to do that for some consults. And we're now in a space where you actually access all sorts of services, healthcare services at home, all the way from preventative and care coordination services, like wellness screenings, primary care in general, etc., to also being able to service at home acute care scenarios. And those include not just ER at home, hospital at home, specialized nursing at home, be it a wound care or an IV infusion, etc., all the way to then the advanced illness type of services around palliative services in end of life. And so this is an example here of Humana's service offering that has partnered, you see, with a very diverse set of third-party providers in order to deliver a very broad range of services from the home. And Humana is not alone in this offering. I mean, we just did a quick search for some other big US healthcare funders. And you can see there that both United Healthcare, Aetna, these are just examples. They also offer a lot of in-home services across the range, also partnering with different healthcare providers. And so building this ecosystem of partners and solutions to address a very broad range of cases. And Discovery Health is on a similar road. And so we wanted to now perhaps talk a little bit about Discovery Health's own ecosystem building in this digital space and what that offering is. I'll start off with just to give you a bit of a sense of the strategy for the year. As you know, we've been on this road now for quite a few years. We started off 10 years ago with a health ID solution for providers. We've evolved the offering into now adding on a connected care platform where providers can actually do virtual consults with members and a number of other features like online patients community, etc., all to offer through there. This came in parallel to already a third platform that was already in use for providers, which was the health professional zone, where providers could already do a number of features connected to managing their practice, such as pre-authorizations, checking members' balances, etc., etc. And so we kind of evolved into the scenario of having 3 different platforms available in the provider space. And one big theme, as you see there on at the top, is to actually simplify and develop a single interface in the provider space, as well as in the member space, who kind of historically also grew, went through that sort of evolution, a similar evolution with the web, plus the app, the corporate app, and the connected care platform. And so create single interfaces that combine all of the features that one can see, and new features as well, that one can see across these platforms. So that's an important theme for the year, and an important focus of these. That will navigate the member through all the clinical and servicing elements that they encounter in global trend, create integrated end-to-end journeys that will navigate the member through all the clinical and servicing elements that they encounter in their healthcare journey. And so, select a few journeys to start off with. We are actually, as you can see there, selected 5 journeys, some more provider focused, some more member focused, but to create really sleek journeys for both the members and the providers that are looking for this type of services. So some around really condition management with particular focus on diabetes and mental health, some around a wellness and how that wellness kind of, a lot of the times when alerts come out of the Vitality Health check, how we kind of nudge the member to continue follow up on those alerts that have been raised. And then on the provider side of things, obviously one of the big journeys for us is hospital at home, as we look to introduce more and more of the solutions in the at home setting. A third theme that you see there is we are very much in this ecosystem build, like the global best practice and the trend has been. We know that we can't build everything ourselves, and that we need to identify the right partners to bring into the digital ecosystem that we're building here. And then lastly, we understand that underneath all of this, we need a very solid, infrastructure base that enables all of these journeys and all of these portals to function and optimally and with core elements that are really, really solidly built. On the right hand side, and you see cutting across all of these themes is a fifth theme, which is increasingly important for us, and we've started already as we build towards the new consolidated single interface, for instance, on Health ID. On the provider side, this new consolidated interface. For us, it's very important to build this in collaboration with the people who will use it, with lots of feedback from the doctors and the broader care team that it actually will be using this interface. And we've started that already with really, really important feedback that we've been receiving as we create this new single interface. So looking at that and perhaps zooming in on how we're imagining this ecosystem, to kind of look like, you will see here that across a number of areas, be it the diagnostic area, acute care, chronic care, or screening, across all of those areas, we are surrounding ourselves or, carefully curated partners that help us achieve really good services and journeys. We at the center of this ecosystem is obviously that single patient platform and single provider platform that you see there in the center. And we are currently, all of the partners that you see in this chart are either already implemented into our platform, and so services that are already available, or they are in the process of being implemented. So we, for instance, finalized all the commercial discussions, and the implementation, the system development is just ongoing at the moment. But it's already a kind of a significant set of partners that we've accumulated now over the last few years. And I would like to zoom in on a couple of partners here, perhaps some of our newer capabilities that have been added to the ecosystem. So you can see, we've got a lot of capabilities around diagnostic, and the VCs is certainly have been a very big area of focus for us. We've, grown a lot the demand in VCs during the time of COVID. We actually increased about 30 times the demand for virtual consults from one year to the next when COVID came. And that has, just like globally, worldwide, kind of decreased slowly after the big lockdowns were over. But it's still hovering at about 5 times what it was pre-pandemic. So we do know that there is an interest and an increased interest, and people have, are now more familiar with this kind of offering and using it. But I would like to focus on a couple of other areas. So not so much the diagnostic area, but the acute care area, where we've launched, recently two important solutions. One is a technological solution to support the hospital at home offering. So you see there the biosensor monitor. We've got a couple of biosensor monitors that we've used. And right now, Biofurmis is our platform of choice to kind of help us with the hospital at home program. And then the other one that you see below there is AI tech. So analytics that we've also brought in and incorporated into our platform that really drive up, you know, the intelligence and you know, the care, the quality that that our patients can access through a digital platform. So let me start off with the hospital at home. Hospital at home solution actually rests on 3 different pillars. The technology pillar that you see there in the middle is just one of the 3 important pillars that this program rests on. First and foremost, it rests on a center, a control center of excellence that is able to basically monitor on a 24-hour basis all of the patients that are, you know, part of the hospital at home program. So this is a care team of doctors and nurses that actually are called on to go to the patients' homes as well, and a number of other allied professionals that are all able to remotely monitor the patients that are part of the program. So that's a very important pillar. The second pillar is the technology part of it. In this case, you see there, we've selected Biofurmis as our main partner. They come with not just the device that remote monitors the patients 24 hours a day, but also the analytics and the algorithms that predict the disease trajectory for each of these patients, so that we can be alerted well, you know, in time for any problems that might be occurring and take the right approach if that is the case. And then the third block, the third pillar that hospital at home program rests is literally the protocols and the best practice that has been used to design the program in terms of who are the, you know, the type of patients that are clinically appropriate to bring onto the program, and what are the right protocols to have if this happens, then what, etc., etc. And this is somewhere where we've, you know, partnered with world-class best practice sharing programs, including from the Harvard, in order to bring and design this kind of protocols and this kind of criteria. So we've been able to launch this program at the beginning of the year, in February this year. And it's something that's, you know, we're definitely excited about and looking to expand into, you know, having started with some more focused areas of acute events, to expand over time to more and more areas and allow this high quality care for people at home to happen at scale. The other one that I wanted to zoom in on is another analytics that we have been using at Discovery, in this case in our home care business, where we've got home nursing events happening at the home of the patients. And specifically one of these therapeutic areas that we cover in our home care business is wound care. And we're leveraging, our nurses are leveraging an analytic platform for wound care called Pixelier. And this platform basically takes a picture of the wounds, as you can see there on the right-hand side of the screen, takes a picture of the wounds, and automatically the AI that is got behind analyzes the level, the degree that's and the type of wound that it is, the type of protocol that is recommended to heal that wound, compares this with a very broad database, wound care treatments, and is able to immediately estimate how long it will take this wound to heal, is able to therefore compare if this wound is taking longer than average, is able to give the alerts. We're able to see that in a very transparent manner, etc., etc. So since we've been using this, and we started off on a kind of a smaller sample size, and now I've been using it across the board on every single wound care. Since we've been using it for the past about 6 months or so, we've actually seen a 5% reduction in the number of visits that our nurses do to the home of the patients. And overall, so these wounds heal. They got the right protocol identified right from the start, and they will heal with a reduced number of visits. And as a result, also a 7% reduction on the average cost of treating these wound care episodes. So this is just another example of digital tools helping in the care of the patients. But we also wanted to give you some examples of digital tools that can also help your practice. And there's a number of them available. And so, I mean, this is just a depiction of the broad range of digital tools that can be used across the different administrative tasks that your practice goes through, as well as more clinical ones. And so you can see the size of the bubble is actually supposed to depict how much time a doctor or in the green bubble cases, a practice manager or a receptionist spends on some of these tasks, and so the number of tools that exist to address and help and support across this kind of broad range of tasks is immense. And those are all solutions that we are wanting to investigate, test, bring about, and make it part of the ecosystem. We definitely think that there's a very big opportunity for digital health to help re-engineering the doctor's practice in a number of ways. And so this is just one more way that we would like to share, because even just by, sometimes it's not around a digital tool, but just a digital dashboard that actually shares and analyzes the data we've got about a specific practice and shows it back to the doctor. This already allows the doctor to gain a much better understanding of the practice they run, see some of the trends year on year, et cetera, and this is one of the examples of the dashboards that we make available for doctors, that gives them a good sense across a number of metrics of the type of population they've been treating and kind of the practice that they run. So I mean, hopefully this gives you a bit of an insight around some of the tools that exist out there, the latest progress around digital health globally, and what Discovery Health's kind of investment focus in this area is. I thank you all for inviting me to speak about this, and I'm happy to answer any questions that you may have.
Good afternoon, colleagues. Let me take this opportunity to thank Ron, Nongu, and Anna for excellent presentations that they've given us today. I think they've mapped out the possible outcomes for the practice of the future and the central role that digitization plays in that space. But more importantly, some of the tools that are already in operation to make sure that you prepare yourself for some of the changes that will be taking place. So many thanks to the Discovery team. We will then go through to some of the questions, and as indicated earlier, Darren is ready to take those. First question there, Darren, is as a GP with a thriving 30-year-old practice, I fully agree with value-based care and universal coverage. I think that's just a comment. The next one is, however, in recent discussions with Discovery regarding the designated provider networks, it was very disappointing to see the inflexibility of Discovery regarding the remuneration for prolonged consultations, where numerous chronic conditions can be addressed at the same time and holistically. Darren, can I ask you to come in on that?
Certainly, thanks, Vusi, and thank you for the question. I think it was Dr. Gassner. So I think we definitely need some more engagement here. Discovery does actually support long consults, but not only long consults, access to monthly management fees for follow-up of more complex chronic patients. So there is the opportunity to get additional support. I'll see later the point about the 50 minutes. We accept that certainly a more complex chronic patient would need longer time than that. And it is supported. Another important program to be aware of is the value-based multiplier program, which also has resulted in the outcomes of those longer consultations. There's additional support to boot. Of course, it is a value-based program, and I'm excited that that there is this general movement within the profession generally towards value-based care, and an understanding that because of the nature and the evolution of the private sector in South Africa, that there is this need for evolution and maybe even transformation of our sector away from typical fee-for-service to these new age disease management programs that supports enhanced remuneration and funding, and not funding for funding's sake, an enhanced resource to support family practice, but that we do need to see the enhanced outcomes and improve generated results as results of that enhanced care. So I'd argue that the chassis for supporting longer-based care to more complex patients is available, and perhaps we should just spend more time maybe at some subsequent scenario or post this session, maybe re-engaging with the practice to make sure that they're aware of what we've got available and the tools that we've provided.
Thanks, Darren. The next question comes from Dr. Odendaal. Any ideas on the digital solutions to improve and decrease medical legal liability in obstetrics? Fewer and fewer obs and gynae specialists, as well as family practitioners, are willing to take on obstetric patients due to the medical negligence insurance cost. Maybe if you could help us with that, I'm sure that maybe Tony might have something to say as well.
Definitely, and thanks again for the question. We've worked very hard with the gynae management group and SASOG, and in fact met as early as Thursday with them again on creating tools to support the medical legal challenges that have been highlighted in the question. We've created an electronic record for obstetric specialists at this point. I mean, if this is, we'd need to work with family medicine to make that more available to GPs providing deliveries, which we know obviously occurs in our environment. But certainly at the specialist level, we've got this joint peer mentorship and peer stewardship program that links to the GMG and SASOG Better Ops program, where there's an easy mechanism to collect data. The point of collecting the data in this way is that having this information at one's fingertips immediately puts the legal profession on the back foot in spurious medical legal claims. It immediately provides evidence as to what happened during the delivery, and it's easily available. And those records remain private to the practice unless they need it in terms of a medical legal challenge. In terms of the creation of those records, there's 3 layers of support that's provided to specialist obstetricians. For participating in the program, we've got a participation fee. For creating a short record, we've got an additional fee. And for creating a long record, which is the most protective for obstetricians, there's a further fee that's provided. And when you actually put all those fees together, you can, dependent on the volume of deliveries that one performs, easily fund even the higher medical legal costs that or monthly premiums that are levied on specialist obstetricians at the moment. So again, it would be interesting if we had more time again to share with those who aren't participating in those programs more on what is currently available.
Okay, thanks, Darren. I'll read through some of the questions that came from, it's a comment, but you might be able to add, some light in terms of the comment itself. Dr. Gazner says that there's a huge difference in time required to see a patient with one chronic condition versus a patient that has got 3 or 4 conditions. How do you see some of the tools that you've put in place can assist in this regard?
As I said, Vusi, we already do offer the opportunity for family doctors to access long consults and management fees that supports chronic care. There is definitely a re-engineering that's happening across the industry in the management of chronic patients. So knowing more about them, tracking them not only at the time at which they see the doctor, just that consult, but having a view of what those patients have been, what's happened to those patients throughout the year, using the digital tools makes those consults more effective, more efficient, and serves for better outcomes as a result of having all that information at the fingertips of the practitioner. So I think it's a combination. One is, as I say, there's this enhanced remuneration that's available for this care, but in addition, there's the extra data that's available that helps one actually support those patients more effectively during the times where the doctor actually gets to spend time with that patient.
Thank you, Darren. We have another question from Dr. Hema. It is exciting to hear that the Indian model will allow you to offer a consultative service for only $4. But the obvious question going through most of our minds is, how will I make a reasonable living from that remuneration?
Yes, and thanks for the question, Mark. I think the answer is that I don't think that $4 price point is a South African benchmark. I think there needs to be different price points for our market. What is clear, though, is that we need to find ways to make South African healthcare more affordable, to give access to this aspirational population to the care that's available, excellent care that's available by South African doctors. We absolutely have to re-engineer to do this. We can't necessarily achieve lower price points providing care in the way that we currently do. There is, though, some minimum standards, of course, that we always have to maintain. Clinical excellence, the level of empathy that's required to be able to care for people in the way that they want to be cared for. So the answer simply is re-engineering. We have to find ways to leverage the skills of different medical professionals to support the treating doctor. We need to leverage knowledge rather than time. In terms of being able to provide more care to more people. That was one of many models that is available around the world where this is achievable, where one can actually support more people, but differently. And I think the challenge that's been thrown out to the South African fraternity is, what does different mean in South Africa? It's not going to be the same as India. It's not going to be the same as other healthcare environments, but that we need a new South African model, I think, is clear, and that we need to be more inclusive to provide more care for more people, I think, is evident. There's lots of innovation going on within the South African healthcare environment, and many practices trying and testing new ideas that we think will eventually lead to creating this model that will serve as a mechanism to provide healthcare for this new market. So part of presenting and putting out this challenge to the healthcare environment is to ask you to join us in how do we pull all these models and ideas together to create our South African future.
Thank you, Darren. I don't have any other questions except for comments in the Q&A forum. Maybe let me give you an opportunity then to have some closing remarks there, Darren, in terms of the landscape as it currently stands, and how do you see us, moving forward?
Thanks, Vusi, and I certainly would. Dr. Whelan spoke in his presentation about headwinds and tailwinds, and while we don't see the environment with rose-colored spectacles, and that we definitely need to acknowledge that there are some challenges that we face as South Africans, as medical professionals, as people who are doing their utmost to supply an excellent service in quite a challenging environment. Some of the challenges are international. The war in Europe doesn't help. Some of the local circumstances also provide challenge. Despite that, there's no question that the environment does not have to be a victim to some of the circumstances that abound. That there is an opportunity to stand up and create a practice within a difficult environment, and often it is in those difficult environments that innovation flourishes. So there are things to think about. How do we manage capacity? The one certain tailwind in the South African environment that Ron pointed to is that there are people that want and are dearly seeking the care that you provide. If we can find the right mechanism to provide it, there's massive opportunity and an opportunity for both not only sustainability, but profitability and success for local medical practice. There's an emerging leadership in South African healthcare as we move forward. And I remain very optimistic that as a result of our ability to innovate as South Africans, which has always been a hallmark of the South African mentality, that we will be able to prevail both now and long into the future. So again, we thank SAMA for the opportunity to share some of these ideas. We really hope that many of them have been food for thought as to what might be appropriate in your individual practices, that, in your particular circumstances. The intent here is not to say that practices need to take on revolutionary change. One of the points that comes up in change discourse is this idea of pivoting slowly, remaining planted in the knowledge and the training and the excellent service that's already available to South African healthcare, to the South African healthcare environment, but picking a few points of change in your particular practice that you think might be interesting to you, but also helpful to patients that you're going to build satisfaction on and add as a particularly maybe a new service line in your practice that is going to help your practice evolve slowly into something that's good for you, good for the patient, but also is going to support the underlying healthcare system in totality. So maybe that as a challenge to those on the call, pick some small piece for change. Some new piece. Anna in her talks spoke about looking into your particular data for your practice and identifying what in your population is important. Is it about pediatric care and maybe a pediatric focus, and therefore pick the tools that might help a pediatric population? If it is about chronic care, there's masses of new innovation that can help you improve and enhance a chronic service. If it's elderly care, there's a massive amount of innovation that exists in that space, and we can go on. So understand your practice, pick the tools that work, and then the challenge is take some small, even if they're tentative, some practices would be early adopters and take more dramatic steps if they feel that it's safe and appropriate to do so. But if you're not in that space, take some small tentative steps to embrace some of these new changes. And I'm certain that it will make your practice more exciting. It will offer more support to your patients, but also be important for the industry. So hopefully, Visi, with that, I hope those are helpful remarks to the delegates.
No. Thank you so much, Darren. Let me take this opportunity to thank the Discovery team, yourself and the other colleagues that are not here, but assisted with the presentation. I'm sure there's a lot of thought-provoking ideas that have been shared as we go forward, and I anticipate that we will be engaging more robustly on some of the issues that we've presented, the tools that are currently being tested. So to Discovery team then, thank you very much. And yeah, we look forward to continuing to interact with you as we look at the different modalities that are being implemented. Colleagues, we've got a 15-minute break before the next session. So if I could maybe allow for a leg stretch break, and request that we come back at 1 o'clock for the next session, which will be on surgery. Prof Goldberg will be assisting us with facilitating that session. So if you could come back at 1 o'clock, and we'll then go into the surgery session. Thank you very much.
For doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for Doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have Discovery qualifying products or not. And it's for doctors in every healthcare setting. We know you go the extra mile for your patients, and that's why we're giving you extra Discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more Discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for Doctors today. With over 750 patients being treated at any one time, we are reimagining healthcare to bring you South Africa's largest virtual hospital.
It was advisable for me to be hospitalized at home.
I was so scared to go to the hospital.
I mean, the comfort of being at home, of course, is first and foremost.
At home, it worked wonders.
Discovery Health Hospital at home. Connect to quality hospital-level care in the comfort of your home through cutting-edge digital healthcare technology.
This little device that they attach on my chest.
It was just brilliant. It was comfortable. It was easy.
Rest assured at home with round-the-clock remote monitoring.
I would be woken up at night because my temperature was spiking.
A clinical care team is on hand 24/7 to check your vitals in real time.
Like they would also call me on a daily basis.
I found the experience very good, professional, the attention to detail.
With a focus on recovery, our supportive services offer medicine and food delivered conveniently to your door.
I felt like I was in very good care. They know exactly what they're basically doing.
Connect with your doctors daily via virtual ward rounds.
The platform has been extremely useful to engage with our patients.
They would always call me in the morning to find out how am I, what.
Your personalized care team is our priority to meet all your medical needs.
Even having bloods drawn, that was done from the comfort of my bed.
Because I felt like I was getting Rolls-Royce treatment, and I said,
and when you need hospital-level interventions, we'll bring them to you. Healthcare professionals are on hand for home visits for your complete peace of mind.
Absolutely, first world-class care.
Connected, convenient, complete care for your hospital stay at home. Hospital at Home, Discovery Health. Reimagining healthcare. How are you today, doctor? Well, you will be now with Vitality Active Rewards for Doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for Doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have Discovery qualifying products or not. And it's for doctors in every healthcare setting. We know you go the extra mile for your patients, and that's why we're giving you extra discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for Doctors today.
Speculation has been about exactly what the president will announce. Will we descend down to alert level 2, and with it, what are the stipulations, all of that?
Because of you.
I fear less.
I hurt less.
Because of you, I'm back at work.
I'm playing with my children.
And our days can begin to feel normal again.
Because of you,
I know the true meaning of leadership.
Of courage.
Of love.
And I see what it means
to truly sacrifice.
All because of you.
To all our frontline healthcare workers.
Siyabonga.
Dankie.
Enkosi.
Thank you.
How are you today, doctor? Well? Well, you will be now with Vitality Active Rewards for Doctors. It's a rewards program designed especially for doctors like you. The best part? Vitality Active Rewards for Doctors is completely free to all doctors in the private and public sector with a valid HPCSA number, whether you have Discovery qualifying products or not. And it's for doctors in every healthcare setting. go the extra mile for your patients. And that's why we're giving you extra discovery miles for living healthier. All you have to do is achieve your personalized weekly fitness goals by tracking your daily steps, by participating at Parkrun, by going about your workday, by participating in My Run, by racing to make a difference between life and death, by working out at Virgin Active or Planet Fitness, or by logging your heart rate during workouts with a fitness device. It's a program made to suit your unique lifestyle, and it's simple and easy to use. Close your fitness ring to achieve your goal, plus get a chance to play on the game board and reveal even more discovery miles that you can spend at a range of Vitality Active Rewards partners, in-store, online, and on travel. Plus, doctors get access to unique functionalities and exclusive boosted rewards through the Vitality Active Rewards for Doctors leaderboard. This allows you to compete for a spot on the monthly nationwide leaderboard to win boosted rewards quarterly and be the healthiest you can be. Doctors in private practice can simply download the latest version of the Discovery app and activate Vitality Active Rewards. Doctors in the public sector can sign up by scanning this QR code or visit the Discovery website for more details. It's just our way of saying thank you to doctors for being the heroes they are and going the extra mile for the people of South Africa every day. Live healthier and get rewarded with Vitality Active Rewards for Doctors today. With over 750 patients being treated at any one time, we are reimagining healthcare to bring you South Africa's largest virtual hospital.
It was advisable for me to be hospitalized at home.
I was so scared to go to hospital.
I mean, the comfort of being at home, of course, is first and foremost.
At home, it worked wonders.
Discovery Health Hospital at home. Connect to quality hospital-level care in the comfort of your home through cutting-edge digital healthcare technology.
This little device that they attach on my chest.
It's just brilliant. It was comfortable, it was easy.
Rest assured at home with round-the-clock remote monitoring.
I would be woken up at night because my temperature was spiking.
A clinical care team is on hand 24/7 to check your vitals in real time.
Like they would also call me on a daily basis around.
I found the experience very good, professional, the attention to detail.
With a focus on recovery, our supportive services offer medicine and food delivered conveniently to your door.
I felt like I was in very good care. They know exactly what they're basically doing.
Connect with your doctors daily via virtual ward rounds.
The platform has been extremely useful to engage with our patients.
They would always call me in the morning to find out how am I, what.
Your personalized care team is our priority to meet all your medical needs.
Even having blood drawn, that was done from the comfort of my bed.
Because I felt like I was getting Rolls-Royce treatment, and I said,
and when you need hospital-level interventions, we'll bring them to you. Healthcare professionals are on hand for home visits for your complete peace of mind.
Absolutely, first world-class care.
Connected, convenient, complete care for your hospital stay at home. Hospital at home. Discovery Health. Reimagining healthcare.
We're now entering the last session, and we're handing over to Prof. Goldberg.
Good afternoon.
Afternoon, Prof.
It is with great pleasure that I'm joining you today, and certainly hope the conference has gone well over the last couple of sessions. I've got the pleasure of introducing two speakers. The first one is Professor Catherine Chu, and she's going to talk to us about backlog in surgery as a result of the COVID-19 pandemic. The pandemic changed everything for all of us, how we worked, where we worked, and what we did. Catherine runs the Global Surgery Unit at Stellenbosch University and is a trained colorectal surgeon. So We have something in common, Kath. Over to you.
Good afternoon. My name is Catherine Chu, and I'm the director for the Center for Global Surgery at Stellenbosch here in Cape Town. It gives me great pleasure to speak today, and I would like to thank SAMA and its organizers for the invitation. Today, I'd like to talk about the surgical COVID backlogs, which I think are an inevitable consequence of our current health system. I have no disclosures. A month ago, the Minister of Health, J Nel, announced that there were over 100,000 elective operations currently backlogged in South Africa after the COVID lockdown. Today, I'd like to talk a little bit about how did we get to this point? So what were the surgical services like in 2020 at the height of the pandemic? What was the effect of the alcohol ban on trauma and trauma volume? A COVID surgical risk calculator that helped us prioritize which of the patients could go to surgery during this time. And finally, I'd like to end on solutions for tackling the backlog. So at the end of March 2020, when South Africa went into our level 5 hard lockdown, hospital services dramatically changed and surgery was no exception. After the first 3 months of the hard lockdown, we did a survey of 85 South African hospitals nationwide to see what has happened to surgical services. Not surprisingly, like other hospital services, there was a massive reduction in elective operations, almost a 99% reduction. In addition, surgical outpatient visits, which is new patients and follow-ups, were also reduced by 87%. Over half of emergency operations were also cut. A third of our surgical staff were deployed to the COVID wards, and 30% of hospitals gave up some of their operating theaters to provide ventilated beds for COVID patients. Another study that we did looked specifically at the numbers of reductions here in the Western Cape. We looked at 6 government hospitals, and the darker line shows the surgical volume in 2019 versus the lighter blue one in 2020. And as you can see, surgical volume was decreased in all hospitals. There was more of a difference in some, particularly the regional hospitals. In this same study, we looked at the estimated surgical backlog for elective operations during the first 4 months. And as you can see, some of the hospitals reported a backlog of at least a year or more in order to address those first 4 months of backlog. Of course, now we're 2.5 years into backlog, and so each of these hospitals would have much more backlogs to address. And also, this was only elective general surgery operations, and there are many more surgical conditions that need surgery than just those general surgery ones. So the backlog is massive at this point in time. As you probably remember, during those years of the COVID lockdowns, we had periods of complete alcohol bans and periods of partial alcohol bans. Anecdotally, the media was reporting, and we found that true in hospitals, that whenever there was an alcohol ban, there seemed to be a massive decrease in trauma volume. However, we weren't sure about the partial bans. So another study that we did looked at trauma admissions and operations, so trauma volume, over the entire 2020 year, stratified by alcohol ban. As most of us recall, there were 2 periods of complete alcohol bans in the very beginning, at the end of March to the end of May, and then again for 2 more months, or for 1 more month in July and August. And during those times, the amount of trauma significantly decreased in this particular hospital. But when there were partial bans, there didn't seem to be much of a difference in the levels of trauma that came in. Another way of looking at that was to plot out total admissions for trauma And during the periods of complete ban, as you can see, trauma volumes were low, but during the periods of the partial ban, the total admissions for trauma were just as high as baseline, meaning before COVID, and even towards the end of the festive season, even slightly higher. Now, one might ask, perhaps this is confounded by the fact that there were also rules about not being out on the roads, and therefore there would be fewer road traffic accidents, or there would be less interpersonal violence because people were just not out and about. But because there were changes in the level 5 to level 4 lockdowns during the complete bans, we were able to tease out the difference or the effect of those laws versus the alcohol ban. And it really did seem like the complete alcohol bans had the biggest effect on reduction in trauma volume. And our interpretation of this is not necessarily that we should always have alcohol bans, although some people would argue that. It would be more than in times of absolute national emergencies. If we effectively want to reduce hospital traffic, then complete alcohol bans, even for short periods of time, are extremely effective in doing so. So during this time, because there was so much decrease in surgical services and the operating theater capacity dramatically decreased, we needed to come up with some way of prioritizing who would get surgery, because there were still patients in need, of course. And the real ethical question was, how do we choose which operations to do? So at the time, there was the National Department of Health had a COVID Ministerial Advisory Committee, and they requested a surgical risk calculator. I am part of a technical working group for national safe surgical care, and within that, in 2020, we formed a COVID subcommittee to look at this. The request was to create an evidence-based set of first, recommendations, and 2, a risk calculator for patients needing surgery. So we established a South African national framework for COVID surgical prioritization. This is published in the SAMJ. And there were 4 key recommendations. The first was to avoid operating on COVID positive patients if possible. Now that seems like a no-brainer now, but at the beginning of the COVID pandemic, it was a little unclear on what the effect of having COVID was on your post-operative mortality. And in the early days, there was a paper that was published in the Lancet, which very worryingly showed that patients who were COVID positive had a 25% mortality rate, whether or not they were symptomatic. And this sort of led to the next recommendation, was to try to do preoperative COVID testing in all surgical patients, regardless of their symptoms. And while again, that seems like common sense at this point in 2022, in 2020, as we recall, in South Africa, especially in the public sector, COVID testing was not available nationwide and so easily. And to be able to test all preoperative patients at every hospital was quite a challenge. Another issue that came up early on was PPE. Again, in the early days, because so much PPE was being used for COVID patients, there wasn't that much left in terms of gowns, masks, gloves for perioperative staff. So again, important to state that PPE would be needed to be available for hospital continued surgery. And finally, the request and the recommendation was to use a COVID risk calculator to determine which patients should be having operations. So this risk calculator looked at 4 different aspects when we created it. The first was facility readiness. So depending on what the COVID pandemic was doing in your particular area and whether you had availability to COVID testing, how sick your staff was, and what beds you had available, you got a different score for facility readiness. Then there were patient factors, and this included the age, the comorbidities, and the functional status of the patient. How likely was the patient going to do well after the surgery? Again, we wanted to prioritize patients who would have a smooth post-operative course versus ones that would be at higher risk for complications. The next was disease factors. How likely was it that if we didn't operate at all, that there would be a change in outcome? So if a patient had was stabbed in the heart, if you didn't operate, the patient was likely going to demise. So that operation or that patient couldn't wait. What about a cancer? Is a 2-week wait going to change the outcome a lot? Probably not, unless the patient's about to obstruct. But 3 months of a wait might actually change the patient's outcome quite a bit. So needed to score or to determine the consequences of delays. And then finally, the procedural factors. So how complicated is this operation? How long is it going to take? What kind of specialists and staff are needed? What kind of equipment? And in terms of recovery, is the patient going to the normal surgical ward, or does the patient need an ICU bed? As you all recall, during the height of the pandemic, ICU beds were very scarce. So any operation that might require one of those would be lower prioritized. So just to give you a little bit of an example of how this COVID risk calculator was used, and just to say that this was approved by the MAC, and this risk calculator was distributed to all the hospitals nationwide in order for it to assist in prioritization. So the facility readiness was supposed to be done every week or every month by the hospital team. And I'll give you an example at our local hospital, Hoteskier. At the end of December, the pandemic numbers were increasing, so the facility got a score of a 5 for that. At that time, it was taking a very long time for COVID test turnaround, greater than 3 days. Oh, pardon, it was that COVID testing turnaround was quite quick, less than 48 hours. But many of the hospital beds had been reallocated, so there was a shortage of recovery beds for the surgery. And the PPE was a bit rationed. So that hospital got a score of 11. A few months later, after that wave was finished, the community numbers were decreasing. The COVID testing turnaround was very quick. There was some reallocation of hospital beds, but not as much as before, and the PPE was adequate. And so at that point, the facility got a lower score of 5. And so depending on the scoring system, you can see that the overall scale of how many operations to do would be adjusted. So again, based on the example I gave, if you look at the very bottom of the PS score, 4 through 9, the green bar is much longer to the right, all the way up to 50, versus if the facility got a score of 11, then you see that middle bar of PS score 10 to 15, where the green bar is only going up to 40. Just recall, just keep that in mind, because as we go on to score each particular patient, the number of cases that can be done was then adjusted by this facility score. Okay, so looking at the individual patients, I mentioned patient factors. So for example, you're going to do a lap chole on a patient who's in her 50s. She has diabetes, but it's well controlled. Her BMI is just a little bit up, but she's got a good ASA, and she can climb 2 flights of stairs. So here she's getting a score of 12. Then you look at her disease. She's got biliary colic. So there is a non-operative treatment, which is to do nothing, but she might do worse. But if you want to wait 2 weeks, it's probably not going to have a big impact. But maybe if you wait 3 months, she'll have another attack, get cholecystitis, and have more complications. So she gets a score of 20 for her disease factors. Now, in terms of the procedure, a lap chole is sort of a medium length operation, usually takes about an hour. The patient goes to the general surgical ward afterwards. She does need a general anesthetic, and she's probably going to stay 1 to 3 days. So she gets a score of 12 for that. So this hypothetical patient then gets a score of 44. But depending on how ready your facility was at that time in terms of the COVID pandemic, in terms of PPE, COVID testing, the patient might or might not go. So when your pandemic score is really low, the score of 44 would be in the green, but when the pandemic score is very high, then that patient wouldn't be done. So what are some of the solutions for the surgical backlog now that we're describing? Well, the first thing to say is that sadly, there's no easy win. Because what happened is that COVID unmasked a weak and unprioritized surgical health system. Even before COVID, surgery was not the most important priority for most of the public health care system. And surgery is mostly done at regional and tertiary hospitals, with district hospitals having very little capacity. The consequence of that is that most surgery theaters at these regional and tertiary hospitals are pretty backed up. And in fact, a lot of elective surgery already gets canceled in order to make space for all the emergencies. There are multiple reasons for this, but at these hospitals there's a shortage of theaters, therefore a shortage of theater lists, a shortage of human resources, in particular of theater nurses, as well as ward beds. So if you don't have the beds, you can't do the operation because the patient does need to recover on a specific ward afterwards. So what are the solutions? Well, I think the most important long-term solution is to prioritize and improve access to surgical care. And that requires a coordinated plan. So the National Department of Health has established a Ministerial Advisory Committee and Technical Working Group on Safe Surgical Care, established last year. And as part of this, what we need is a fully costed National Surgical Anesthesia and Obstetric Plan, abbreviated NSOAP, that is embedded and aligned with the National Health Plan and the upcoming National Health Insurance. In other words, how are we going to deliver surgical care for all persons? Because even before COVID, the way it was, many people did not have access to care. As a part of that, we really need to improve district hospital surgical capacity. Because at district hospitals, first of all, there isn't much surgical capacity, but secondly, surgical specialists, and when I say surgical specialists, I mean general surgeons and all the subspecialties within surgery, the anesthetists and the obstetricians, they're usually not working at district hospitals. As we all know, for example, most cesarean sections at rural district hospitals are done by medical officers, community service doctors, and even interns. But in order for district hospitals to improve their surgical capacity, we need to have guidelines and, more importantly, provide support for doctors who are providing surgical care that are not specialists. So, for example, at a district hospital, what type of surgical procedures would be safe to do there? Well, firstly, we need to come up with a package of care that's appropriate at the district hospitals. We need to choose ones that are of high burden of disease, so for example, abscesses, but are easy to perform and don't require anesthesia that is too complicated either. So there are some procedures, for example, lower limb amputation, that might be technically easy to perform by the person providing the surgery, but because the patients often are high risk because they have diabetes, a long smoking history, uncontrolled hypertension, basically vascular paths, then the person providing the anesthesia, who again probably isn't a fully qualified anesthetist, might feel uncomfortable. Also, people performing surgery at district hospitals need to have guidance and a continued linkage with specialists working at the regional and tertiary hospitals, and that thus far hasn't really happened. Each facility has been functioning in its own little world, and either they provide specific services or they don't, and they might refer the patient, but usually without a lot of coordination between the different levels of care. We definitely need to train and fund more operating theater and surgical nurses. Of all the human resources that we're short of at the moment in South Africa, it's the nursing staff. And then what about the short-term solution? When the Minister of Health says that we have 100,000 patients backlogged who have elective surgical conditions, how are we going to address those? Well, I think that other than also looking at the long-term solution, one of the things is to look at the backlog from a regional or district point of view and not a single facility. So for example, if the ophthalmologists at one hospital say that they have a cataract waiting list of 40 patients, they shouldn't just think about their particular patients, but in the entire region. So here in Cape Town, we have the Cape Metro, which is divided into East and West, but each of those regions, the Cape Metro East or the Cape Metro West, can look at all the facilities providing cataract surgery and pool the list and try and figure out how to address the backlog in a coordinated way. And again, the reason for that is because certain hospitals might have theaters but no staff. Other hospitals have staff but no theaters. And so if all the resources are looked at together, then more of these cases can be done. Of course, within each of those conditions, which ones are the ones that should be prioritized? So the ophthalmologist will say, we've got cataracts to do. The orthopedic surgeons say we have hips to replace. The general surgeons say we have hernias to repair and gallbladders to remove. But between all these surgical specialties, how do we prioritize which conditions we want to address? And there are several factors that need to be considered, which I won't go into here now, but certainly it's the cost of the procedure and the cost effectiveness. So once the operation is performed, how likely is that going to address disability? Some hospitals are trying to add on extra elective lists on the weekends. That is possible, but again, oftentimes the staff is too short. I should mention in that article that we wrote about how long it was going to take to address the surgical backlog, we added on one additional case for each weekday, plus on the weekends, to the normal amount of surgery that was being done if the hospital was fully functional. And don't forget that depending on what's happening with COVID, because COVID isn't over, many hospitals are not back to 100%. They might only be at 85%, which is actually only worsening the backlog rather than making a dent in it. And finally, the other solution is to move staff and facilities and patients around. So where there are theaters available. And then the final possible solution is to partner with the private sector. So in COVID, the public sector bought out ICU beds from the private sector for COVID patients. So that actually worked quite well in terms of sort of a fee for service, if you will. And the private sector has the capability to do a lot of operations that the public sector doesn't, especially sort of the bread and butter ones that are on the backlog list. And so if it's possible to partner with the private sector, this would be a great short-term solution. It would also be a way to explore for the upcoming NHI, when private and public services will be pooled, how the two sectors could work together. So in conclusion, there is a very large elective operation backlog, but this stems from chronically poor access to surgical care, even before COVID. A surgical health system strengthening approach is needed in order to resolve this. And certainly a surgical package and strategy will be needed for the upcoming NHI. That comes to the end of my talk. If there are any questions, I will be happy to answer them. Thank you.
Catherine, thank you very much. I see that there's nothing on the chat.
Prof, there was a question in the Q&A, but I've typed in a quick answer there, but I don't know if the person, Mark, wanted to ask it.
Let's have a look. Noting the obvious fiscal constraints in South Africa, would it not be a good idea to use the private sector as a waiting list initiative like the NHS in the UK? What do you think, Catherine?
Mark, I'm not sure what you meant about the private sector as a waiting list initiative, meaning that public sector patients should be put on the private sector list?
I think that's what's probably meant.
Yeah, I mean, I think the first question would be, does the public sector want to collaborate with the private sector? And I think that, you know, the real only precedent for that were the ICU COVID beds. I think that moving now towards the NHI, the lines between public and private will become more blurred. But I certainly think that since in private, there's a cost associated with all aspects of surgery, there could be a price put on each package of care around each surgical condition. So for a lap chole, for example, there could be a certain cost And that could be sort of the starting experiment, but that would be if the public sector had money for that. And thus far, most of the public sector is saying we don't have money to address the surgical backlog in any major way. So I'm not sure if that's going to happen. Thanks.
Thank you. If there are no more questions, Catherine, thank you very much. Is there anything else in the Q&A? No. Clearly, fiscal problems are going to be a major issue going forward, and we're well aware of those. And that is the, how shall I put it? One of the major things that we're going to have to overcome in moving forward in terms of healthcare in this country. Thank you very much. I'd like to call upon Ken. Ken Boffard. Trauma in COVID. Now, Ken was head of trauma in Johannesburg, at Wits, for many, many years. And he's now like me, sort of playing and doing things that we want to do. Is that correct, Ken?
Absolutely, Paul.
Thank you. It is fun.
I think the key here is we're having a lot more fun and a little less of locking of horns with various government administrators.
True that.
I think we're going to pre-record it, if I'm not mistaken. Good day, everybody. Welcome to this SAMA symposium. My name is Ken Boffard. I'm Trauma Director at the Mill Park Hospital in Johannesburg. We've been asked to look at the effect of COVID-19 on the trauma over the last couple of years. Were we affected, and what did we learn? Well, when it first hit the shores, this was pretty much the sort of impression you got. We really didn't know what we were dealing with. We had read about it overseas. We got a few people back, and everybody started treating without any regard to the circumstances. We knew so little about it. We knew it probably had come from China, or maybe from skiers in Italy, or was it only bad flu? Or no, it only hit patients with comorbidities. And in the search for all of this, we made some wrong decisions. We do know that the lockdown was instituted over 5 stages, 5 alert levels, and everybody is familiar with them. And I'm just going to go over the history of COVID a little bit before I talk about how we had to deal with and respond to it. The lockdown timeline, as you're aware, in the first few months started around the 26th of March, which is when, or 27th of March, when hard lockdown began. It was released to level 4 and then level 3 lockdown in June. But by the end of June, there was something like 3,500 new cases a day. We knew that social distancing might help. Whole new point for hospital trolleys or for supermarket trolleys. We knew that functions had to be restricted, and those who didn't faced the full arm of the law. And then we had our Minister for Cooperative Government saying, we haven't really just decided this off the top of our heads, and inevitably we are going to be making some decisions. Our regulations have been challenging, and we've had to amend them. And if you don't like the ones we've got, we might find others. And there were the abnormalities. For example, you could buy sheets in the supermarket after the first lockdown, but not towels. Not quite worked out the rationale for that. We know that the daily infection rate started immediately, and you can see on the red line where a lockdown was brought into and matched at that stage pretty much the rest of the world. We also know about RT. So up to June 2020, we thought we had this held, and indeed we did for a while. We were running at a little over 1, so the numbers were going up. And then by the end of June, the numbers started going down and everybody breathed a sigh of relief. And by the end of August, we were pretty close to relatively less normal COVID limits. In August, we were down to 0.5, and everybody relaxed and dropped their guard, I think. And then pretty much we know what happened. Because by October, we started getting a spike. In January 21, which is where we were going up to, we had over the Christmas period there, and beaches were shut and so on. And then it just kind of grumbled on. The big spike you see on your right of your screen is actually the Omicron, where we didn't have nearly as many hospital patients. The other thing that South Africa has a significant number is unreported COVID deaths, otherwise known as excess deaths. So there were all of the public relations things. No masks, you could infect each other. One mask, well, somebody's protected. And two masks, well, now do you get what we're going for? Did it work? Yes, we believe it did help in control. The Mill Park Hospital is a 450-some bed hospital with a slight surge capacity. Around 1/3 of those total beds are ICU beds made up of general and specialist ICU and a further 46 trauma beds. Relatively few were negative pressure beds at the outset. And we had to convert a lot more to negative pressure because what is very clear with COVID is you really don't want it spreading around. And fairly early on, these ICUs were converted. I'll come back to how we did the red, yellow, and green zones. There are a total of 9 ICUs in the hospital. We looked at the flood of stuff coming in that could not be curtailed, cardiothoracic, trauma, and a small number of generals. The remaining 6 ICUs, 1 was a patient under investigation, PUI, and 5 were converted to full ICUs. So inevitably, of the 120 beds, we had something like 100, it's 120 non-trauma beds. We had around 100 full red ventilated COVID beds. It affected our staff, but we had measures in place. Ultimately, we had 10% of our 1,500 staff became infected with 3 deaths. Transmission was noted as patient to staff and staff to staff. Visiting was banned fairly early, but staff still had to commute to work. And so there was staff providing some degree of cross-infection. We also, as knowledge became more apparent, looked at how it was being transmitted, and it was clear that there was aerosol transmission. Chest tubes and ventilators initially were capable of transmission, and there was sheer panic about tracheostomies, and there were all sorts of models on how we dealt with it. So our statistics by June or July was that we had around 100 COVID patients in hospital, 55 occupying ICU beds, and the rest in the wards. And we were running about 12 to 20 deaths per week. Ultimately, our experience was we had 7,000 patient days of COVID patients with greater than 1,000 ICU bed days in June 2021 on COVID alone, with 65% of the total hospital was COVID positive. This meant that our hospital had the highest number of COVID admissions in the entire group, but we also had the lowest mortality. And we think that we're very fortunate because we managed to get organized as a combination of really proactive working from the corporation and equally a very careful response from all of the professional groups. We also had the highest number of ECMO cases. We have 12 ECMO beds at capacity, but we never needed more than 7. And as I mentioned, we ring-fenced trauma and cardiothoracic beds. Because the reality is, as much as COVID is important, people die of other things, and we had an obligation to protect both groups. First thing that was established was a Clinical Joint Operations Committee, or JOC. This was a regular meeting once a week with about 30 people held on Zoom. We are probably the biggest private trauma center in the world outside of the United States, with up to 100 major trauma admissions per month. So trauma, because of the unplanned nature of itself, is very well protocoled, very structured, with a tier system, a hierarchy, and written protocols for everything. So one of the very first things that we did was said, it worked for trauma. COVID, heaven knows, is unstructured. Let us structure and put protocols in place, drive them, and review them. So we started with trauma and COVID teams doing the same thing. The hospital was divided into 3 zones. Red, which was positive COVID. Yellow was under investigation, and we were fortunate in that our laboratory gave us a PCR return time of between 2 and 4 hours, really from the beginning, and then green were clear. So the decision, for example, was that trauma and cardiothoracics, because of the pressure on them and their beds, would be ring-fenced if at all possible and kept for green patients only. We set up a PUI ward and a PUI intensive care, and in the trauma area we set aside 4 holding cubicles until we had cleared. I'll come back to each of these. The emergency department was cleared a yellow zone, and I'll show you a picture shortly, but the reality was that patients who came in, if they were overtly COVID, were put into a red holding area. All other patients in the intensive cares and everywhere else were in a yellow zone with barrier nursing that you see there, not full COVID kit, but barrier nursing until the PCRs came back. All don and doffing stations were monitored 24/7, and I think the very low transmission that we achieved with transmission of disease was because there was at least an enrolled and more likely a registered nurse 24/7 in each donning and doffing station. Doffing because that actually is probably where you're most vulnerable, putting and watching the gowning, watching the gloving, watching the sealing, watching all of the ways it was done to make sure there was no contamination. The team for JOC and everything else had anesthesiologists as very much part of each team, with designated anesthesiologists with particular training in terms of the intubation. We intubated using video laryngoscopy wherever possible. And the COVID itself was treated by 3 pulmonology teams. Protocols, as I mentioned, are written, and in trauma we do those every 2 years, and we did that. We're actually on iteration 6 of the intensive care protocol. And to give you some idea of how the protocol is broken down, that is not an exhaustive list, but that is the sections that looked at in the protocol, starting with treatment guidelines, admission criteria, what are the ICU admission criteria, because there's going to be a greater demand for ventilators than availability of ventilators. In fact, there wasn't. We ran at one stage around 55 ventilated patients with COVID, and we still had some reserves. We had dedicated COVID theaters, both for trauma and for non-trauma patients, so that if there was a PUI or COVID patient, they could be dealt with in isolation. But we, although restricted routine operating surgery, we were able to run other theaters. Modifications included, as I mentioned, an intubation team with an anesthesiologist on, and we had 3 teams so that they were on 1 in 3. All patients who weren't obviously red were treated as PUIs, and therefore yellow zones with this appropriate bacterial protection. They all had a PCR on admission, and any surgery that could be delayed for the 4 hours or so that until it came back was done. We used closed circuit ventilation. We had no wall CPAP, and one of the easy things that it was to modify in the trauma situation is that we put viral filters onto our chest drain bottles, And it did mean that whatever the patient breathed and bubbled out didn't bubble into the atmosphere with COVID in it. The protocol was dynamic and evidence-based throughout. We are very grateful to a number of experts, both from overseas and both province and the private sector, and a particular salute given to our intensive care specialists, Professor Richards from Joburg, from Charlotte, and others within our own team, because it was all talked about at the JOC, consensus driven. We had a COVID protocol subcommittee. It was presented to the JOC, and if there were changes, they were introduced. We very early on banned the use of off-label drugs, and those drugs either could not be used or could only be used if there was further consultation. We instituted antibiotic stewardship because it became very clear that people had initially been using blunderbuss-mycin of whatever they could, carbapenems and so on. And in an ICU environment, that's a recipe for resistance. So we have an antibiotic stewardship committee which concentrated significantly on that. No value in the drugs that you see there, and they were abandoned fairly early, together with things even like vitamin D and zinc and so on. It felt that if there was not appropriate clinical evidence on a global basis, we had enough problems without clouding the issues. As I mentioned, there are 3 medical teams in rotation, team A, B, and C, so the same teams were working together. We had a specific intubation team, a zoned nursing team. We had specific counselors who previously had been just trauma counselors, but now acted as support both for the patients who were awake enough to receive support and, in fact, for relatives, a lot of it by Zoom. We had staff support, and the company actually set up an electronic support and assistance line. What that meant was 2 levels. One is anybody, because visiting was prohibited, anyone who had relatives had a hotline. They could phone the phone, and it could leave a message. The call takers would find out the condition of the patients and come back. And then as time went on, we started having iPads in the ward where patients could talk to their relatives using the iPads. And finally, we felt it was important that the staff feel responsible for each other's welfare. And there was a lot of encouragement, both in terms of supporting the staff and in terms of making sure that the staff supported each other. Being started, I don't know if the sound is coming through on this, but one of the things that we did was set up Jerusalem. What you can see in the background is the COVID red reception area, so that patients who were going to be admitted and needed holding for a bed, we held them in the containers until the beds were available, so that the red patients didn't have to cross over anywhere where there were green patients or anywhere else. Trauma, what were the effects on trauma? Well, we have had 30 ventilated beds, and we turned 4 of those ventilated cubicles into negative pressure cubicles for either COVID or PUI patients until the PCRs came back. Those effectively were therefore reception areas where we could do full resuscitations without necessarily blocking up the emergency front line, because every trauma area in the emergency front line was at some point being used, and with up to 50 COVID patients a day needing resuscitation, the load was huge, and I think that's right across the country. Our beds are positive pressure, so it's another reason we couldn't make them as COVID beds. We kept them as green beds throughout. We had extubation protocols, and as I said, we had a trauma manual and a COVID manual. Patients who did go positive there were a few. 300 admissions over that particular first year period from effectively August until at least May until September, October, we had 300 trauma admissions. 25 of them went positive after admission. And no matter how good you are, you're only negative based on your last test. Just to remind you the effects over the last 2 years, we had a relatively low peak in June. We had the beta variant in December to January 21. The biggest surge we had was in July with the Delta variant. And as I said, we had in that particular one over 1,000 ICU bed days. And then the last one with the biggest peak of all, with around 40,000 new cases a day, was the Omicron. And apart from Britain with red hotels, we weathered that quite nicely. What is interesting is that our 4 to 5 peaks have come down. Britain is still running at a significant level, although from nearly 1/3 cases a day in January, they're currently seeing around 2,000 to 3,000 cases a day now. Pradeep Navsaria and his colleagues in Cape Town produced a very good paper based on their experience of the first 3 to 4 months in trauma, and they noted that the total number of their patients decreased by 50%, the gunshots decreased by 15%. That clearly meant that there were a large number of beds that were freed up from trauma that could be used for other things, and they showed an 80% increase as a bounce back. Decrease in car crashes, proportion injured. Pre-lockdown, about 16% of what they saw, dropped to 8 to 9%, and then post-lockdown ballooned again. So what did we have at Mill Park as the biggest private trauma centre in South Africa? This is 2019, 2020, and 2021, the year before the year of big sick COVID, and 2021 was also the spike. And I draw your attention to the pale blue in 2020, that is the middle of the bars in each of these. And you can see that compared to March, April and May, our number of patients dropped dramatically. By June, with lockdown 3, it had surged to almost pre-COVID levels. June to July, we locked down again. And then after August, it has stayed pretty constant. However, like the rest of the country, our trauma is rising now. And as you could see in May this year, we had the highest number of trauma patients we've seen for 3 years. It's reflected in similar fashion in the number of non-threatening cases. We had a significant decrease of all cases in that April lockdown. If we look at the deaths, it's not surprising that since we had fewer cases, this is again a pale white bar. If you look at April 2020, you can see that in April and May, we had far fewer deaths. Burns admissions likewise went down because people were not allowed, and a number of organizations and workmen's compensation and others all shut down. So our admissions from burns, electrical fires, and so on dropped dramatically. The blunt injuries dropped less than the penetrating injuries. There were falls from height. The penetrating injuries did drop somewhat more dramatically, and have started rebounding. Certainly you can see that in the 2021 group, by July and August, they were coming up again. So overall effect, gunshots went skyrocketing this year, and compared to 2021, a lot more. So overall, with the initial lockdown, we had a reduction in gunshots and a change. Most of the previous gunshots were crime outside. That was substituted with the lockdown of groups of people. Alcohol was freely available no matter what the law said. Groups of people, 6 to a room, living in central Johannesburg. An argument ensued, usually sorted out with guns. So the total number of gunshots dropped. The nature changed. The percentage of injuries in 2020 and 21, blunt to penetrating, did not change. So the numbers dropped, but the ratios pretty much the same. So the effects on trauma throughout the country, but slightly differently from Cape Town, the initial lockdown caused a dramatic reduction and freed up beds. That being said, when the beds were really needed, which was a year after the first COVID, it wasn't quite as helpful. Alcohol caused some reduction, but actually alcohol was available if you wanted it, unfortunately, or otherwise. Cars were not on the roads. There's no question of that. Drunk driving was not a problem, but there were far more domestic disputes. There was a slight reduction in gunshots, unlike the Cape, where they had a reduction in the total number. We had a transient reduction, but the change was where the gunshot happened rather than numbers concerned. And while the cars were off the streets, much better. Second lockdown, not as clear-cut. And after that, it's been just like it was before. We are a violent country. Only 2/3 of our drivers are belted. Unfortunately, at least 10% of all road crashes that we see, the participants are over the legal limit. And there was a significant increase in suicides and self-harm. COVID statistics that I pulled this week, 29th of July, just to remind you, it has not gone. In South Africa, we are just short of 5,000 active cases as we speak. We have very few deaths, but we do have 350 plus new cases a day. It has not gone away. We do hope that everybody is still taking some precautions. Unfortunately, masks may have some influence, but are not used now. Vaccination unquestionably has had some effect. And I think that this is now an endemic level where we have to live with it. Trauma is back to or has exceeded what it was pre-COVID. Law enforcement is more stretched. We are drinking more, I suspect, rather than less. The effect is the load on the country is greater in patient terms than it was before. The virus is still active, but it's now often symptomatic. So patients don't know if they've got the disease. Very few of them blame anything other than flu. So to all our professionals and everyone watching this, the virus is still active. Are you or your friends or your relatives the next host? It's there. We just have to be aware. And I don't think in the history of mankind, the speed with which knowledge of COVID outstripped anything else. The Spanish flu took 3 years to get to where we were with COVID in 6 months. Vaccination. We had vaccination within 6 months or starting. So there have been spin-offs. Thank you very much for your attention. Enjoy the rest of the symposium.
I'm trying to turn on my video. Thank you very much, Ken. That was fascinating, as always. Some of the effects, I'll start my video. Some of the effects we swore at, clearly did make a difference. Certainly getting cars off the road. Do we have any questions? From the audience. The audience seems very quiet. Or we just get to... Yeah.
I think one of the things I've tried to highlight is from pandemonium at the beginning with the lame leading the blind. What I tried to highlight is no matter how bad things are, if you have competent organization led by competent groups of people, province or private, the results are better, the organization is better, and the sheer angst is more controllable. So that if we have anything further, I hope that the lessons learned are not just to treat COVID, but also to look at how organizations and how they organize can in fact be improved.
I mean, the response was absolutely remarkable, wasn't it? Internationally and locally.
Yeah.
It was really something special. Do you think it made a huge difference in terms of the run of the pandemic? Do you think it shortened it? I mean, the flu epidemic, 1917, 1918 flu epidemic, ran for 3 years. The flu is still around. We're still 3 years down the track.
It will still be around for a while. I think it's a great question, but I think the reality, and I was fortunate enough to see a public broadcasting film on Cremona in Italy, looking at the teams within the first month and watching what subsequently would have been a break of every single rule in the book. No masks, no gloves, handing body fluids and then wiping their faces, because nobody knew any better. And I think if you look at the sheer mortality rate, firstly, people will still get it. But what is clear is in the initial few months, if you went into hospital and ended up in an ICU, you ran a 50% mortality. 1 year later, we were running with a more severe form of COVID, a 10% mortality. And that is the extent of knowledge that has occurred in that year, and learning the hard way what did and didn't work, and removing some of the witchcraft.
Yeah, I can clearly accept that learning about the condition and the rapidity of the learning factor. What I'm trying to say is that, 3 years might be in the natural history of a pandemic like this. And although we may have reduced the death rate through vaccination and ICU, have we really stopped it or not?
I think we're more resistant to it. We probably had the desired herd immunity, wittingly or unwittingly.
Yeah, no, I'm sure we have. Right, there don't seem to be any other questions. Dr. Naidu, some closing remarks. Sorry, Dr.
Klapo.
Yes, Klapo.
Okay. Thank you, Prof. Goldbeck, Professors Chu and Boffard, for an interesting session. I would also like to thank all the presenters that were part of the program today, and more importantly, to thank all colleagues that have been with us from yesterday to today. We've come to the end of the session for today's proceedings, and would like to invite everybody again to come back and regroup with us on Saturday the 13th. Will be the very last session of Summer 22, Summer Conference year 2022. With those words, just to thank everybody for having been with us today, and look forward to meeting with you again on the 13th of August. Thank you very much.
Thank you very much, Professor Chu. Thank you for a great talk.
Thank you, everybody.